Thank you. They were recording. Awesome. Good morning. Welcome to BBBS on November 14th. So why don't we go ahead and do a roll call, please?
One moment while I get up the agenda. Oh, goodness.
I can do it, Jessica. I've got it right here.
Thank you. Sorry.
So Holly Joe.
Here.
Hodges, Adrian Irwin.
Here.
Max Kaiser.
Here.
Catherine Schabel.
Here.
And Brian Judy.
Present.
Mary Engrove.
Here.
And did I miss anybody? Lucy Langer. No. Antoinette. Oyaki. Sarah Love will be missing. Kristen Zone.
Here.
David Sanger cannot make it today. I think that is everybody.
So are we expecting Antoinette and Lucy?
Antoinette, yeah, she was gonna call in and then be here shortly, but we do have a quorum, so we can go ahead and proceed.
Okay, and do we know about Lucy Langer?
Lucy, I wasn't sure whether she was gonna come, so we shouldn't wait for her.
Okay, got it. Great. Okay, if anybody has the opportunity to look at the minutes from last time, we entertain any changes or comments regarding that. And otherwise, I'd entertain a motion to approve.
Motion to approve.
Thank you. And second by Brian. All in favor, say aye or thumbs up.
Aye.
Aye, great.
Mary Beth? We got an aye from Mary Beth.
And Chris, I can see Chris there, so great. All right, do we need to do introductions or anything in the room?
I don't believe we do, but we should do the opportunity to declare public conflicts of interest.
Okay.
Do you want to say something? Do you want Jason to?
So just if any member has a conflict of interest or personal interest to declare with regard to one of the many items on the agenda, this is a chance to say so. If there are none, we will go ahead and proceed with the welcome slides. Liz, can you bring those up? Mary Beth, we are getting a lot of noise from your phone. Can you mute when you're not talking? Thank you. Okay, so as a reminder, OHA has set a goal to eliminate health inequities by 2030. Our purpose here today is to make coverage recommendations for OHP. These decisions will affect over 1 million OHP members and their families, caregivers, and providers. We will not be making any decisions about individual care this morning. These are decisions about coverage, benefits, and medical necessity for the Oregon Health Plan. We will have some public comment a little later, probably quite soon this morning. These decisions made this morning and early afternoon will not be final until approved by HERC, and then they will be implemented at later dates. Some of them today will not be implemented until 2027. Most of them will be implemented in January. As always, our considerations include the assessments of the balance of benefits and harms, patient values and preferences, good stewardship of public resources, and just the nature of our healthcare delivery system and how people access services. Next slide. And Daphne, unfortunately, I need to announce, is on medical leave, so she is not here. So Jessica and Liz and I will all pitch in to manage things. But you can message Jessica when you're stepping away or departing if you're online. Anybody can send a Q&A to Jessica or enter a question if you have logistical issues or have trouble hearing or whatever. Members, if you're on the phone, Mary Beth, please unmute and vote that way. If you're online, please do so in the chat. If you're in the room, please make sure you're heard, and Liz will note it in the chat. We'll have to cooperate. Daphne usually monitors the votes, and so we'll have to make sure we have 6 votes to carry a motion today.
Do you need?
Jason, Antoinette just called in.
Wonderful. So we now have even more quorum. Welcome, Antoinette.
Great, thank you. Do we need to log in, all those of us that have computers sitting in
You
front
can
of us?
log in,
and
but
then-
please don't join audio if you're in the room.
Right, but would you like us to all vote in the chat so you can?
No, you can vote,
It's
if you're
fine.
in person, you can
Okay.
vote verbally, I'll note it.
Yeah, you,
Okay, great.
Liz is taking notes here.
Got it.
Okay, if you're online and I don't know that we have anybody this morning online offering verbal testimony, but we wanna make sure that Zoom name matches the registration. Again, the Q&A is there for you, and the chat and the Q&A are part of the public record, and the meeting is recorded and will be posted online, so you're live on camera. Any questions, concerns, something you'd like to revisit? herc.info@oha.oregon.gov. We will respond as soon as we are able to. So with that, I think we can go ahead and move forward. I will be giving, the staff report is next, if that's all right, Holly Jo?
Yes, please.
Yeah, we have a few things that are not on the agenda. I don't believe we had any errata this time, is that right, Liz?
It was,
There was an errata? Okay. And there was an errata in the packet. We're actually not gonna be talking about factors other than evidence and decision-making today. The benefit update project we'll be talking about at 11, but there are a couple other things I wanted to go over. We are still hiring a part-time medical director. Ariel has been doing a yeoman's job of working through the unfunded region, and we really appreciate help. If you know a great person, please put them in touch. If you know of somebody who is interested but saw something they didn't like in the application, please also let us know and we'll be in touch. With the packet, you'll notice a few changes today in your packet, and we'll have more going forward. So I would like to get feedback. Some of you responded to our survey, but some of those were incomplete, and so we actually are phasing it in today. And you'll notice on the issue summaries that Ariel prepares, where she summarizes the studies, they're hot links to the studies on that. And so in the next, and those will get you, in some cases, they're paywalled. And if you have, if you want to see those studies, you'll need to go to the member-only packet, which we also will continue to produce. But if you want to just click on the articles, you'll get the website, and I think we're not gonna include the PDFs of the abstracts anymore. That should make our packets shorter. The other thing we're thinking of doing is making one packet for both VBBS and HERC. Because without those articles, it'll look very much like the HERC packet, and also make life easier for our staff. But please let us know if you have any concerns about that. But that's our plan going forward. Part of that is due to some accessibility requirements. And another part of it is due to Senate Bill 1508 requires a lot of redaction. And this is a way to keep things like quality adjusted life years out of our packet, but still provide access to the important information for you all.
And just to be clear, I mean, for the most part, the VBBS packet and the HERC packet are the same, other than the research that is proprietary.
Correct. Yeah. Well, no, the proprietary research is put in the VBBS packet. Yes, that's correct, in the members only packet. But currently, we don't even have abstracts in the HERC packet. So we'll just make it all one packet. And if an item is only on one group or the other, we'll just note that.
Okay.
So we'll probably put the HERC only items at the end, since that's the way the day goes. Any other questions or thoughts about that?
Jason, this is Chris, real quick. I'm just trying to get set up. So for me today, would it be more useful to have the handouts that are listed or the materials?
So
Which one is
We're gonna need both.
yeah, so there was a pretty substantial handout, more like a little mini packet that you all should have received on Tuesday. And that was because we received the HICPIC codes very late. So we are gonna be kind of toggling back and forth during the meeting. We'll use the packet and then we'll go to the handout and then we'll go back to the packet.
And
Okay, thank you.
we will be announcing the page numbers, and we've got those in good shape today, so that should go better than it's done the last couple of meetings. So we will do our best to keep you able to navigate things on your own there. Any other questions on the packet or on following along?
Jason, sorry to interrupt. Sarah Love just joined us online.
Wonderful, welcome Sarah.
And just as a reminder to committee members, when you're voting, please just do a direct or do a message in the chat. If you do a direct message to me, that it's harder to count. I can still count it, but just FYI.
Thank you. Yeah, please chat everyone with your votes. All right. With that, then we have Senate Bill 1508. Oh, first of all, yeah, let's mention, we have a special guest today. My predecessor and mentor and former boss, Darren Kaufman, has joined us in his new role coming out of retirement to help out the team. He is doing CCO rules as a policy analyst for the Medicaid division. He is also a key part of the benefit update project. Do you want to give your quote, Darren?
Oh, my quote is, I brought the prioritized list into this world and I'm taking it out.
So welcome, Darren. Nice to see you here again. Yeah, and with that, let's go on to Senate Bill 1508. So this is the bill on quality adjusted life years that passed the legislature last session. It takes effect January 1st and have some updates on that. First of all, there is a report due. The biennial report will contain a new section, and that section is about the use of quality adjusted life years going back to 2006. So we are scrubbing past meeting materials. We've gotten back to 2012 or so and looking at all the quality references and making sure nothing was denied because of quality. And if it was, we were going to look at that topic and consider whether we'd make the same decision in the absence of quality, so that there may be some topics coming forward as a result of that. The second part is the Disabilities Health Advisory Panel. Again, we had some listening sessions. I talked about those at the last meeting. I don't really have any updates on those today, but we are continuing to work on scoping that. We also are, as I said, we'll be changing our meeting materials. And one of the reasons is this, but also starting with this packet, we had Liz do an analysis of any references to qualities in the meeting materials. There were a couple. But she ascertained that they did not influence the recommendations. And so that's what we'll just continue to be doing going forward. We'll make sure that happens before you all see anything. And the final piece of that, and this is a part of the bill, is we are working with the new contractor. And we will, I hope to have something to announce at our next meeting, and we need to put the vendor out for public comment, their name, and give an opportunity for the public to comment on the selection of that vendor. Any questions or thoughts about the Disabilities Health Advisory Panel or any other part of 1508? All right. And finally, we are approaching the preamp, or what do you call it? The pregame show for the legislative session, the long session. We expect there to be some HERC-related activity, certainly related to the benefit update project. Don't have a lot more to share right now, but stay tuned. And if you hear anything we should know or would like us to know, of course, let us know. We'll collaborate with you all as partners in this work. I think that is all of the staff report. Did I miss anything, team? Okay. With that, we're ready to get started with the main agenda.
All right, Ariel, we'll go ahead with the straightforward consent agenda, please.
Yeah, so we first have the consent table. There were about 10 items on there. Did anyone want to discuss any of them? And then there was one straightforward guideline note change, and it was just adding a code to the guideline. Any concerns about that?
Can you speak up?
So, yeah. Does anyone have any questions about the consent table or the straightforward guideline note changes? Anyone want to discuss any of that issue? All right, then we'll go on. I have been meeting with lots of specialists, and sometimes during these meetings, things are coming up that are super straightforward that we just need to correct. So you're going to be seeing some of these coming forward at each meeting. The first one is ophthalmology. There was one diagnosis that actually is a form of Bell's palsy that should be moved to the Bell's palsy line, and then the ophthalmologist asks for enucleation to be paired with corneal ulcers. I doubt that's going to be misused, so I thought that was a pretty reasonable ask. And then the other ophthalmology issue was anophthalmos, which is a sort of usually a traumatic mid-face issue that they have to kind of reconstruct the eye socket. And the experts thought that this should be on the craniofacial anomalies line because these are typically things that need to be there. Plus they wanted an orbital implant, which is where they put in a glass eye. If we do that, then we can strike through line 479, which is anophthalmos, and orbital implants, and then we will delete that in 2026. Anyone have any concerns about that?
So is there a trauma line and a congenital line, or did you just combine them?
They're all gonna be combined,
Okay.
Conditions with no eyeball, yeah, that's one, I like it.
or so much damage that they
Acquired or
need to,
transferred, yeah.
yeah.
So does it all go under 254?
Yes, it's all gonna be on the craniofacial anomalies line. That's where all the repairs are for mid-face trauma. And then we're gonna add the orbital implant, which they would use if you had to remove the eye due to trauma, or it was not present due to a birth defect. Any questions about that? I met with the breast surgeons. They brought up that we currently don't cover aspiration of breast cysts, that this is actually a diagnostic test. Most breast cysts are benign, but typically they'll do an FNA, they'll draw out the fluid, and if it is not benign, infected or cancer or something, then they will treat it appropriately. So the recommendation is to move breast cysts and then the puncture aspiration of the cyst to the diagnostic file.
Does every cyst need to be aspirated diagnostically?
No, but right now you can't aspirate any.
Yeah, I'm just wondering, like, what's the ratio there? Because if we just put it as diagnostic, it's allowing a ton of procedures that might not need to be done.
You tried to talk a woman out of aspirating the cyst in her breast?
I mean, I've tried to talk to them about similar issues, yes. I mean, if it's painful and symptomatic, that's a very different thing, yeah. If it's painful and symptomatic, that's a different thing, but if it's just on imaging and it's simple, and do we want to say all of those cysts we should be aspirating, because there's not.
I don't think we have to say that they all should be. I think we can say they all could be.
Yeah, sorry, yeah, is that what we want to be saying?
Yes.
Does that carry over to any other simple cysts that we're seeing elsewhere? Like, is that being consistent that we're allowing that sort of
No,
diagnostic?
We have FNA of almost everything
Okay.
else.
If it's consistent, that's fine.
Yeah.
I mean, I'm not sure it's always medically indicated, we're supposed to be evidence-based, right, we're saying. But if there's no great way to delineate that, that's consistent.
It's a gray area. It's also really difficult to talk a woman out of it.
Yeah, when people are concerned about lesions on imaging or whatnot, or they can feel, well, right, no matter where it is in the breast, it's a little more sensitive for sure, right? Both physically and emotionally, right? So, but I'm just thinking consistently and medically speaking.
We can monitor these codes, and if we find a huge uptake, We actually already are paying for, if they're just using it as like a, not breast, like just a skin cyst or something,
Oh,
they're
they just code
probably
it differently?
already coding it somehow.
Okay, well, I mean, that might be our mistake. No, let's work, but I think monitoring sounds fine.
But I mean, these codes are related specifically to the breast.
Right, but I think she's saying that we might already be paying, if they don't code it breast, we might be paying for it right now anyways. And that's like a glitch that we're not monitoring correctly, not argument to then also approve these.
But we are not paying for, so this came up from the breast surgeons saying that when I asked them, you know, what issues are you having? One of them was when we have cysts and we
Oh, we certainly need to
aspirate,
cover them in many
we're
scenarios.
getting denied.
Yeah, I think it's totally fine to just watch it and see how they're used. I think that's what he's.
I'm just trying to think what other codes would be being used that wouldn't, most of the codes that would be being used would pop up because they're being submitted with the non-funded condition.
But if they're diagnostic, doesn't matter. Right?
They could be breast lump, I think that's diagnostic, but
Breast lump.
yeah, breast mass, breast lump.
Right,
Yeah.
I'm just, you're not gonna aspirate a lump. But I don't think we.
But if we
that
pay
either.
for that, they might code that,
Right,
you know, training people to.
Right, we have not set it up correctly. Yeah, I think monitoring is fine. That's a good.
So does anyone else have any concerns about this? Anyone else want to discuss the breast list? And then, the dermatology folks, there was a couple of conditions that could lead to death that we aren't covering. That should be. And then there were some lupus diagnoses that should be covered for medication therapy that are cutaneous lupus. And so the ones that lead to death are things I've never heard of and that are super rare, and hopefully we're covering them now if they're hospitalized, but this will kind of get ahead of that. So we're adding 4 diagnoses to a covered line, and that for the, you know, serious kind of things that might lead to hospitalization, and then 2 cutaneous lupus codes to the same line as other lupus codes. Skin cutaneous lupus.
And so we're on page 60 of the public packet. And Ariel, I think we missed the excluded guideline thing. We wanted to push that.
Oh, yeah, sorry, that's in a different.
I'm sorry, but go ahead and make sure we're finished with this one.
I have a question. I'm just curious. I see Stevens-Johnson syndrome up there, and I'm just wondering, I mean, that's such a common adverse event. Where do those things get covered? Because I'm surprised that that's not somewhere already in our prioritized list.
So these are really uncommon but very serious, and we would have paid for them if you were hospitalized. Like that's
okay.
a different.
I see.
Hospitalization is different. They use DRGs, they use other things.
Mm-hmm. Okay, thank you. That clarifies it.
Yeah, and I've never heard of a couple. Well, erythema multiforme, yeah. Any objection? Any other discussion? We should probably vote. Oh, the excluded guidelines, are they part of the consent agenda too?
They are, but let's vote on those separately. I think they might be more interesting.
Okay, so everything we've discussed so far, if there is a motion to approve as presented.
I move to approve as presented.
Thank you.
Consent agenda items presented so far.
And seconded by Brian, all in favor say aye, or please note online in the chat. Great, all right. we can-
Mary? All right, thank you.
Mary, you said aye, in case. Okay.
I think we're unanimous in the room. Let's go ahead.
Yeah,
Right, so the excluded guidelines is actually in the packet that came out on Tuesday, so I told you you'd have to go back and forth, I apologize for that.
So this is on page 2 of the handout that was posted on the meetings page yesterday.
So currently, I'm sure you're all familiar, we have guideline note 172 and 173, where we put things that are either have much less costly, equally effective alternatives, or they are experimental, or they just don't have supporting data. They are attached to two uncovered lines. Hearings is having, so hearings is where people can come and talk and have their case heard before an administrative judge. The administrative judge has a question about whether, because these are attached to lines, they need to have the comorbidity rule applied. And that's what's been happening recently at administrative hearings, is that they are requiring the comorbidity rule because they are on attached to lines on the list. And this is
Non-funded ones.
non-funded lines. Comorbidity, again, is when a non-funded condition can affect a funded condition, and you need to consider that. And they have requested, and there has been a lot of discussion amongst the different groups at OHA who deal with this kind of thing about what the best way forward would be. What we have come up with, and that hearings feels it would be the most effective, would be to actually strike through lines 495 and 654. So they'll, on the 1-1 list, they will be struck through. On the 1-126 list, they will not be there. And then spin off the guidelines so they're not attached to lines. Instead, they will be called excluded services guidelines. They'll be excluded services guideline 1 and excluded services guideline 2. That indicates that HERC has looked at them and does not intend that they are covered for any condition. And then we'll have to modify multiple other guidelines that refer to guideline note 172 or 173 to have them refer to excluded services guideline 1 or excluded services guideline 2.
What's the comorbid argument? Because they're either not least costly or we found they're not effective.
Yeah, we had trouble parsing that, but it's more of a technicality that the administrative law judges are asking about. Well, how did you consider the comorbidity rule? And this should simplify it because it will appear on MMIS provider.
Yeah, I get it's easier. I'm trying to understand their logic, because even if you say the comorbid, it doesn't get
Because
past
it's-
med nec.
Because it's on a non-funded line.
No, I get why they're trying to apply it, but then you do the next step, is it med nec, med appropriate, and then what's the point of this argument?
It apparently was
It does make more
causing
sense.
issues for hearings and they were worried about adverse DOJ rulings and.
Okay, it makes more sense. I was just trying to understand what the argument is, and cool. Okay.
Soberly.
And after all these years, apparently it's now a problem when it wasn't
Yeah.
before.
Well, there's,
And this will actually, I think, work better with the BUP project.
it totally makes sense. I was just trying to understand what the argument is.
What the problem was
Cool.
we were trying to fix. And
Cool.
It's,
I mean, there are
I'm not sure.
new judges involved. That's
Yes.
probably where this is coming from, my assumption, but okay.
Oh, looks like Chris has her hand up.
Hi, thanks. I'm just trying to understand, and I'm a little concerned that, like, if the excluded lists, it just seems like there's a lot of stuff that could be on there that we have or have not addressed. So is there, and it's clear to me that if we've addressed it, that it would end up there. But it seems like it could open up a huge scope of work. And I'm wondering, is there a process for some containment or like a way for them to check in when these things come up? Does that make
think-
sense?
Yeah, I think, Chris, it'll be like it is currently. So we have a date of last review, and for things that are commonly requested or used, we are trying to review them every 5 years. Staff acknowledges there are things with really old dates on there. A lot of those have never been requested or it's never come up. So we don't have any staff capability to look at everything on those guidelines on a routine basis. That's beyond our staffing. But if anyone wants us to, we will definitely do a review and update our date of last review so that it's obvious to everyone, especially, if something's on there and hasn't been reviewed in 15 years, it would definitely be needing another review.
Well, the other thing is there is an administrative rule that says before something is denied, if it hasn't been reviewed in 5 years, consult with HERC as to HERC's intent. If it's not been reviewed in 5 years, it needs an individual review by a medical director to be denied. So there are some safeguards in there.
Thank you.
Great question, thank you. So other thoughts, anybody thinking about this? It seems cleaner.
And I think with the benefit updates, it'll be
Oh, yeah.
fast.
No, my office staff is thrilled. So,
Okay.
all right, so let's vote on this separately, this little piece here on the excluded guideline change. Anybody willing to make a motion to approve it as written?
So moved.
Thank you, Brian. And I'll take a second. Thank you, Marion. All in favor, aye, and put it in the chat, please. Aye.
Aye.
Awesome. So we're
We're moving on to automated
Racing
home
ahead.
blood pressure monitors.
And we've got a couple people to testify, and this is page 63 in the public packet.
of the public packet, not the extra packet, and are we on the agenda 5, right? We're into new discussion items?
No, this is the last of the straightforward, it's just we have public testimony, so we decided to call it out.
Okay, it's not on my.
Second page.
Did you say page 63? Is it about blood pressure monitors? That's what I get.
Correct.
Public testimony okay, thank you.
Oh, it is new discussion, I'm sorry. It is new discussion items.
Okay, there we go.
So this item comes to us from the Medicaid programs, and it's the American Heart Association. Is the correct?
Yeah, American Heart Association, we had put American Medical Association.
I'm sorry.
It is
So-
the American Heart Association.
So currently, Oregon Medicaid only covers the old-fashioned manual cuffs where you would need to use a stethoscope and also, listen for the pulse to know what your blood pressure is. These are not straightforward to use for many people. This rule was made many years ago, and we were asked to look at the evidence around automated blood pressure cuffs. These are the ones that you frequently will see that someone can put on their arm, and it will just do its own thing, and it will give you a number. And this has been requested because we only cover the HCPCS code for automated blood pressure cuff if no one in the residence is able to safely and accurately assist with a standard blood pressure cuff, but pretty much it's very difficult for most people without medical training to use a manual cuff. The American Heart Association is moving forward with trying to increase the number of people who are monitoring their blood pressure at home, finding it more accurate for both diagnosis of high blood pressure conditions as well as for monitoring how well treatment is working. So they were also requesting that we look at this. We reviewed home blood pressure monitoring as a service. This is when a clinician recommends somebody have a home blood pressure cuff, and then they can send in their readings, and the clinician, it's like the clinician can then look at the blood pressure readings and say, do this or that with your medications. Those were added to the preventive services lines and the lines with hypertensive heart diseases. So we never reviewed the HCPCS codes for the cuffs, which is normal. We don't normally review A codes, which are DME. But those codes are not reviewed. The CPT codes for the physician services for, or the clinician services for responding to patients with blood pressure issues are on the preventive services line. Our evidence review, there was a review in 2022 looking at the diagnostic accuracy of sort of the manual versus the automatic. They found 4 studies, and they suggested that they're equally accurate at monitoring blood pressure. So this went out for public comment. We did receive public comment on this. The main request in that public comment was that the staff recommendation did not include line 1 pregnancy, and there are many hypertensive diseases of pregnancy. Staff absolutely agree that home blood pressure cuffs should be provided for women with pregnancy, any pregnancy complications or other issues. And there was some submitted literature regarding the use of blood pressure cuffs for pregnant people. And then the USPSTF recommends that you screen for hypertension. The other payer policies that I could determine, it looks like they all are paying for the automated blood pressure cuffs for people with any kind of issue. So in summary, currently OHA is restricting coverage to manual blood pressure cuffs. This is not really feasible for a lot of people. You need training that can be, even for people with medical training, sometimes it's a little bit difficult to use. The automated cuffs are equally accurate. They are being covered, and so staff is recommending that we add coverage for the automated cuffs. And there are two options for doing that. We could either make them ancillary, so they would be available for anyone for any condition, or we could add them to lines. These lines would include the pregnancy line, preventive services line, and then the hypertensive and hypertensive heart disease lines. And there would be a new guideline that would basically say that home blood pressure monitors are included on these lines for diagnosing and monitoring hypertension, including hypertensive diseases in pregnancy and related cardiac conditions. And they would also say automated monitors are preferred as first-line devices.
So before we discuss, I just want to put for the record that Antoinette Awachi is here in the room with us now. Welcome. Thank you for joining us. Good to see you.
I know we have public testimony on this topic.
Shall we do the public testimony first and then we can chat?
Or does anyone have any questions about just the specifics for me before we do public testimony?
This is Chris. I just have one question from
Yes.
my own practice, so it might be skewed, but in those studies, was there any differentiation in the accuracy between the wrist cuff and the arm cuff? Because I have not seen good evidence with the wrist cuff in my practice.
I did not review evidence on that, but I think that is the general consensus in the medical community.
So I guess this guideline is written very broadly, and I don't see that.
Well, I don't know that we can, unless there's specific codes, Chris, we can't differentiate between the two. And so I believe that the codes will cover both and it's gonna just be whatever people want, but.
Is it a place we could put a recommended? The way we do with some guidelines?
It depends on where we end up putting.
Well, there's a
these-
guideline.
Yeah, we could in the guideline, we could say,
Even if it's an ancillary guideline?
it wouldn't really, I guess it could be, it could be enforceable, but I don't know, you can't do it from the codes.
No,
You'd have
there's
to do a
no way
review.
there's no way to enforce it. The cost of a blood pressure cuff and the cost of reviewing a PA doesn't really make sense.
But you can put in the recommendation.
We can certainly put in the recommendations and encourage people to not use the wrist things.
Automated arm monitors are preferred as first line?
Even that recommendation, I think, helps when you're in an organization that's covering the cost for these or fronting it. Like, even I think that's where if they have an option, then, if there certainly are cost constraints, but I just see it cause a lot of anxiety for clients when they get those wrist cuffs, and then we do a lot more, reassurance and reevaluating with them as a result.
Yeah,
So I
we
think
can
it could be a cost savings both for time and be more helpful for the client. Just the
We could do
recommendation.
Automated arm parentheses non-wrist monitors are preferred.
Yeah, something.
Because
They're easier to use. It's just there's so much about the wrist thing that's positional that can lead to variation. And yeah, I've seen the variation. Thank you,
All right.
Sarah. I appreciate the nods.
I think that works.
Were we gonna talk about which lists to
Hang on.
use?
We'll do that.
After
Oh,
public
that's after,
testimony.
Okay, who's up? Who's in charge of? Liz,
Testimony?
please.
I'll go ahead and do it since Daphne's not here. So we have a couple of people here to testify. Sorry, we were missing Daphne. Sending
Yeah, we
love
are.
to
Jason, would
Daphne.
you like me to announce them?
If you're ready, that would be great.
Yes. So regarding automatic home blood pressure monitors, we have Silky Anderson and Laurel Durham. And let me promote you guys to panelists.
They're here in the room.
They're here.
Oh, they're here in the room. Oh, excellent. Never mind.
We would invite you
Do you want
to
to
sit.
sit over there?
I was the one that emailed you yesterday that it wasn't on that list, but I said I was told if I came in first.
Yes.
Yes.
Okay,
Yes,
sorry,
please.
my name wasn't called, so I didn't wanna take a seat.
No, she's first though.
So we're actually gonna have you sit here because it's, it allows you to be on camera for our folks. So we are asking that before you give your testimony, please state your name, any organization or affiliation that you're representing, and any conflicts of interest.
And a testimony timer will be
Yeah,
on
the
there.
timer's right
Oh,
there.
3 minutes,
Let you
okay,
know.
great. Hi, everyone, I'm Silke Akerson, I'm the Managing Director of the Oregon Perinatal Collaborative, and I have no conflicts of interest. The Oregon Perinatal Collaborative is Oregon's perinatal quality collaborative. Each state has a PQC, and our job is to look at maternal and infant outcomes around birth, and then make quality improvement around where we have excess maternal mortality and morbidity, and infant mortality and morbidity. And we are seeing a really significant increase in hypertensive disorders of pregnancy in Oregon and across the US. And those are a major driver of severe morbidity and mortality in Oregon. And the greatest opportunity for prevention of, especially around deaths, is in the postpartum period. And we are actually currently in a quality improvement initiative to help address maternal and morbidity around hypertensive disorders of pregnancy. And we're working with half of the birthing hospitals in Oregon, which is about 2/3 of the births, on this initiative based on the Alliance for Innovation in Maternal Health toolkit. And one of the main barriers that we're finding is actually around the access to insurance coverage, Medicaid coverage of blood pressure cuffs for people in pregnancy and postpartum. It's really inconsistent across CCOs whether they provide coverage, and then there are a lot of barriers to coverage throughout the process. We're trying to do a pilot project to make sure that people have access to a blood pressure check within 3 days of discharge after after their delivery hospitalization if they had any hypertension diagnosis during the pregnancy or the birth. And the best way for that to happen, especially that soon after the birth, is for someone to have a blood pressure cuff at home where they can have a telehealth visit and report that. But it's not consistently covered. As a midwife and someone who's taught a lot of midwifery students, I can tell you trying to teach people to use a manual blood pressure cuff in a short period of time and have that be accurate is not feasible. We are really hoping to have this be something that's consistently covered by OHP for an arm cuff, not a wrist cuff. There aren't validated cuffs, there are very limited validated cuffs for pregnancy and postpartum. So we hope that it won't be restricted actually to only validated cuffs because, as you all know, in medical research, there's a lot of bias against including pregnant people and a lot of feasibility issues. So often in the good intention to restrict things to validated products, it often penalizes pregnant people. There's still, we sent a letter with some of the research that is available around this, but there's still a lot more research needed. But what we've seen in the evidence is that access to blood pressure cuffs, especially in the postpartum period, reduced postpartum readmission rates, increased attendance at postpartum visits, reduced racial disparities in care, and helped with hypertension follow-up. So it's an essential tool for making sure that people who are newly on medications during their delivery stay are adequately medicated and getting feedback to their providers about that. And it's also really useful for people who are identified as having risk factors during the pregnancy or delivery, and then will have like an actual trigger for knowing whether they need to contact the provider or come back in. I think I'm at my 3 minutes, but I'm happy to answer any questions if you have any questions.
Can I just ask on this project you're talking about, you're not advocating that every pregnant woman go home with a,
No.
okay, so only those 20-30% that have some sort of a hypertensive issue?
Yeah.
Okay.
Any questions online?
Chris has one.
Hey, Thank you for doing the study. That's wonderful. I think that's very powerful, and hopefully you'll have more of those good outcomes. I was curious in your study, telehealth has just come online in the last couple of years, and you mentioned that as a tool. Is there an outcome or metric that you're also looking at with the telehealth?
We're not looking at a specific telehealth measure, and this is a quality improvement initiative, not a study. So we track the data for quality improvement, but not for publishing. But the measure that we're looking at and that the Alliance for Innovation on Maternal Health uses is a postpartum follow-up visit within 3 days of discharge for people who had any diagnosis of around hypertension in the pregnancy or delivery stay.
And so
that
that could be either telehealth or in person?
Yeah, that could be either telehealth or in person, but it can only be telehealth if that person has a home blood pressure cuff.
Oh, okay, great.
So they have to have a blood pressure check to meet the measure.
And that visit, are you getting coverage for the visit?
It should be, we have a pretty robust telehealth coverage.
Well, that's a really big topic because the way that this care is normally paid is through the global OB fee. And if you ever want to get into the global OB fee, we can talk about that for a long time. It's really not adequate for the high risk care that people are providing these days, and it's really not adequate for the changing recommendations about increased postpartum visits. It was a package.
That's a topic for a whole nother, nothing you can do about it here.
If you don't deal with fees, I would recommend that you talk to the
We talk with
Medicaid
everyone
division.
about it all the time.
Yeah, okay.
But it's
Unfortunately,
useful for you all to know.
not anything we can
They're not
impact
things,
here.
yeah.
So,
Thank you
very much. All right, our next speaker, please.
Good morning. For the record, my name is Christina Bodemer. I am a senior government relations lead for the American Heart Association. So I'm recognizing that my usual audience is lobbyists and not medical professionals. So I'm going to skip over the first few paragraphs that I have written out talking about how hypertension is a chronic medical condition because talk about preaching to the choir. Really, where there was one potential conflict of interest that is very far removed, but I will flag it. The reason why I am here, in addition to flagging this for HERC of being an issue that I'll talk about why we found out about this, is we are actually looking for the additional requirement of a validated list. And that validated list is from, although it's put together by the American Medical Association, the American Heart Association does sit on the advisory board that comes up with the criteria of how those are determined. So the U.S. blood pressure validated device list is the first U.S. list of blood pressure measurement devices developed to assist physicians and patients in identifying blood pressure devices. The VDL, or the Validated Device List, is a public health service supported by the American Medical Association, and I flagged that because in the packet it did say it was the American Heart Association's list. We hope it is not our list. This is the list that we're hoping that you all will include in your requirements. We have been working on a blood pressure lending library with many FQHCs. That what happens when a patient is diagnosed with hypertension, is on a new medicine protocol. They take a lending library cuff home. They have their blood pressure under control. They get their device. It's not validated. Suddenly the whole process starts over and they're back to the lending library, even though the money has been sent on a blood pressure cuff that is supposed to be their own. The only way to make sure that the new automated devices have kind of like transformed the market. There are hundreds of them. And it's really increased the ability to develop self-monitored blood pressure programs, which is exciting. However, without this VDL, there's really no way to know which one of the products on the market are validated and are able to give appropriate readings. So the nice part about this is most of the cuffs that are on the VDL are actually under the allowable reimbursement of that $52.38. So this does not, at its face value, increase cost. It's just providing an additional kind of reassurance that a device that a patient is receiving to help monitor their blood pressure has gone through an additional rigorous testing to make sure the numbers they're receiving are accurate. So that is why we're here urging in addition to changes from manual to automated, that there's that additional requirement of a validated list being used.
All right, great, thank you. Good job. Spot on. Any questions, concerns?
Well, what populations do they validate in? So pregnancy would be one, or pediatrics, or is it just adults?
You know, I have not dug in to what the validated list includes, actually, until I was chatting on the side. Did not realize that there was a differentiation of what was validated for postpartum. I myself was hypertensive in pregnancy and was given a validated device post. I do not have the answer to that, but I would be happy to look into it. I apologize. Again,
No need to
lobbyist.
apologize.
There are like 14 clinical tests that every device has to go through to become part of that validation.
And this is Chris. Can I address the equity question in kind of looking at the population again? Are you seeing differences in who is receiving the cuffs, who's coming through with them, and what their outcomes are?
So we actually have a program that we partner with the American Medical Association in to actually create these self-monitored blood pressure programs called Target BP. And it does, we're focused our work on FQHCs and other like clinical settings where we are hitting the people who are most likely to be hypertensive first. I would be happy to follow up with more data around what I can disaggregate that's not protected medical data to answer that question.
Can I add one thing to that? About the equity issues? The thing that we've found is that while there are a number of validated blood pressure monitors, we can't find a validated blood pressure cuff in the XL size. So there's limitations to what's been like researched and validated. It's been a real issue because we're doing this pilot project of paying for a number of blood pressure cuffs for these participating hospitals, and they want to have, you know, a validated cuff for the larger cuffs, but we have been unable to find a validated XL cuff, which is a huge
Just come
equity.
Together.
It's a huge equity issue because we have a lot of people who need an XL cuff.
Or these days, XXL.
There's 21 on the list for XL.
But is
On
it the
the-
cuff?
Not for the monitor.
Now, come with cuffs.
That's what I would think.
I'm looking at the picture. I mean,
If you validate the monitor, doesn't that mean you had to validate the cuff you
there's
used?
only, not in XL, there's only 3 for pregnancy and 1 for peds.
Alright, well,
So they're mostly adults.
three and
My
one.
understanding was that the automated cuffs have an ability to adjust, I guess, for the difference in girth in a way that like a manual cuff can't. There's no feedback in the manual cuff to understand that you're not compressing enough or that there's a.
And I think that's true if the arm is smaller, but not if it's bigger than where it wraps to the line.
If I can add
That
one
makes
thing,
sense.
one of the reasons why we're also doing this work nationwide is to urge more manufacturers to submit their cuff for validation. So for clinical accuracy, there's no reason they haven't, there's just not a carrot
Yeah, exactly.
for them to be able, which requirements like this may also solve some of the problems around pregnancy where more manufacturers recognizing that their product is not eligible will submit for validation.
Okay,
That doesn't answer the question right now, but it is a hope for later on.
right. Thank you. Great presentations. All right, I'll open it up to the panel for discussions, questions, thoughts. If you don't come up with some, I have some of my own. Hurry up.
I like that things are validated. I think it's a problem in some of those special populations. I'd be fine putting the validated for adults, not for peds, no ped, but I think we also have to kind of think about it, see what access there is to those different devices in the different communities.
Well, I
Like
like the fact that
that's-
she said that primarily, that the primarily validated cuffs fit under that price point, so that
Yeah, and I'm looking at them.
pushes
They look
that
pretty
way.
available, but there's things
Um,
I don't know sometimes about access.
and again, as the PCP, I always had my people bring your cuff to your appointment, we'd check it against ours, if it was horrible, we'd throw it out for them and you'd get another one.
It's consistent, change the number. Yeah.
Right,
Yep,
so,
yep.
I mean, there's always, you know, we gotta trust our providers are paying attention. I know Max thinks I have to trust.
So Mary Jo, when you've done that with your people, have you had an issue getting that second cuff covered?
It's Holly, Joe,
Oh my gosh, I'm so sorry.
and it's quite all right. And I haven't been in primary care practice for quite some time. We used to just give them to the patients back in my day,
Yeah,
because we had them stocked up.
in my practice, I haven't heard of any patient not being able to get a second cuff, but that might reflect private paying patients or Medicare patients more than, I don't know.
I mean, generally on OHP, you replace DME every 5 years, and it needs to have been stolen, lost, destroyed, non-functional. You know, there needs to be some documentation of why you need another one in less than 5 years. If we put this on the ancillary line, none of it will matter.
A lot of CCOs, like, we don't review if it's this cheap anyways, right? So even if it didn't work, nobody would even look at it anyways. But that also speaks somewhat to waste, right? We don't want to be just saying we'll pay for anything if it ends up being.
No, we don't, but I think we need to open access to these, just,
The other benefit of the ancillary list is people who aren't diagnosed, although that could be the preventive services line.
Right, isn't that
People who
what that
are,
in it?
have risk factors or have other things where they're not yet maybe diagnosed.
I like that preventative lens.
right, but I also think if by putting it on the ancillary line, if somebody's physician tells them, hey, you need to go, here's a blood pressure cuff, they can just go get it.
Yes.
It won't matter what condition it's for.
Are we kind of jumping conversations? We want to say which ones we cover and then how we want to cover it on the list?
Sure.
Yeah, because that was like, those were two different conversations,
Yeah,
right?
so you have two questions. You have which option, do you wanna have them on lines or ancillary? And then once we make that, that might be a good first decision, and then once we make that decision, we can look at our guideline and
Then we can
wordsmith it.
All right, so, does anybody have strong feelings other than me about where this should be placed?
Because you're thinking if we put it on lines, what's the chance the provider knows about the preventative service line? Like, it's
And have to come
incredibly
up
low.
with a correct code,
incredibly low,
and
right.
again, we're not gonna review these at PA, but there might become
Right.
claims edits, so.
There's not a lot of providers who are just saying, everybody get a blood pressure cuff. There's usually a reason that it's discussed.
We'd like them to.
Right, so. Yeah, I'm fine with that.
Okay.
Doing the ancillary.
Does anyone
I like the placement for ancillary. I am not convinced that we're at a place where we can, I would rather not restrict access to validated. I think just even
Hang
differentiating
on,
between
Chris, we're
arm
still
and.
on the one, hang on,
Oh,
still
okay.
on the one topic here,
Got
so. If there's anybody else, any other comments, otherwise I'm gonna take Max's.
It'll be option 2, which is on the screen. It'll be ancillary, so.
Oh, okay, so
so
can I
live
move
for-
to,
I
I motion
I'm gonna
to
take
add it
Max's.
to the ancillary guideline? Is that better?
Ancillary file.
Sure, Max, would you like to second that?
Second.
Okay, the second from Max, everybody in favor say aye. Aye. So it's on the ancillary file, thank you, Mary. So now let's talk about what the guideline note looks like and whether or not we want to put the terms validated in there. Again, recognizing that our ability to enforce that is minimal to none. Our willingness to enforce it is little to none. And that it could just be more of a good faith thought. It'd be more of a recommendation and best practice kind of statement.
I would say add it then, if people aren't gonna be held to it, and at least brings awareness that list exists.
Well,
So if I can reassure you, Chris, it should not present a barrier because of the fact that there will be no way through coding that it would get stopped if, because there's no codes for validated versus not validated blood pressure cuffs.
Okay.
It
Yeah, that
could
sounds
be though, I mean, especially HSD, they sometimes get into the weeds about what they allow and.
If that's the way they want to spend
Well,
their
I
time and
think
money, go for it.
The word preferred might carry some weight here.
Mhm.
Maybe
So we could do automated arm non-wrist monitors, validated monitors, and arm
What?
preferred.
The other thing I think we need to think about is how do we define validated, and people are gonna wanna know who validates.
On the American Heart Association valid.
It's
Medical
It's the AMA.
Association.
It's the AMA.
That's okay.
So now it's the AMA, and we should put a link in.
Yeah.
We should put an active link in so that people can hit on it and find the list that you found so
It's
rapidly.
validatebp.org.
So automated,
They got good marketing.
That's good.
Yeah.
That's really
so automated arm non-wrist monitors validated by the American Medical Association, parentheses, link.
Can we, so is there a way to separate that? So there are two statements. So arm non-wrist monitors are recommended, preferred, are validated by.
Non-wrist and validated monitors are preferred.
There are some wrist ones on the list, so.
There's a proper name of it, the US blood pressure validated device listing. If you
Okay.
wanna just call that out instead of referring it to Medical Association, Heart Association.
Yeah.
Yeah, no problem.
So automated arm non-wrist,
But there are validated wrist ones, it sounds like.
There's a decent amount of
So-
validated wrist ones.
So let's go back to Chris's thought here, and maybe we make it 2 sentences, because my master's tells me we shouldn't have these long run-on sentences. Automated arm non-wrist monitors
Which are, that are, like you need like
are
Recommended,
recommended.
preferred,
Best practices or preferred.
yeah. I think best practice is great because then that really does speak to like where we see it in clinicals, even if it doesn't have a study.
so we could do automated arm non-wrist monitors are preferred as first-line devices. HERC recommends consideration of devices on the US blood pressure validated device list.
I would change that because we reviewed the research on the monitors, so are recommended because we reviewed them. And then the second line, I like the word preferred.
I'm with
because
you.
we-
Flip
Okay. So go back to automated arm non-wrist monitors are recommended as first-line devices, because again, we reviewed the data. HERC prefers, yeah, sure, devices as, HERC prefers devices to be,
Which is
Validated,
the-
prefers validated
to
devices.
be, yeah,
Prefers
prefers
devices-
devices validated by the US blood pressure validated.
Or listed on the,
No, that's fine. HERC prefers devices validated by the US blood pressure validated device listing
I
link.
mean, prefers validated devices.
Oh,
Yeah, I think it should say, HERC prefers devices on the,
list. Or included,
or included, yeah.
first devices included.
Are we preferring or are we recommending? I mean, I don't.
So we're
prefer seems
preferring
like
the
such a
second-
Squishy.
Well, I know,
word.
but we're preferring the second part because we didn't do the validation ourselves. We're recommending the first part because we did the review.
But the review didn't differentiate between wrist and arm, right?
Didn't,
No,
right,
Uh,
so,
oh, I thought you're right.
Yeah. That's why I just put prefer for everything. I just put prefer.
Okay,
I just think if you don't
That's
separate them,
something
there's going to be a lot of restriction to just using that validated list. And then you're going to run into that problem where the things that are not covered or are rarely, there's not as much. It's the equity piece you're restricting in terms of how it gets interpreted. If you put them on different
I
lines.
think if
Well-
we say preferred, there's no,
nothing binding about it.
There's no
there's no
teeth.
restriction, there's no teeth. We're just saying that that's best practices, but
We're giving people a consideration or an idea of where to go to get a high quality one.
What if you added where possible at the end of that
Oh,
sentence?
yeah.
Yeah, I like
And
that.
then that identifies that there's an acknowledgement that there's populations that may not be well reflected by this list.
Simply possible.
Do we say prefer in other guideline notes? 'Cause there's other guideline notes where we suggest things. I'm running out of versions. I can't pull them off the top of my head. I
Wait,
know
why
they exist.
prefer instead of suggest?
Well, usually we recommend,
I think it is probably too.
but I think
there
this
one
is
in, like,
fine
the
for
smoking
this.
guideline? We do
I
this?
think
That's-
this
okay.
is fine for this. This is.
I like
this-
that last line though, that it does,
Guidelines.
it may not it may not reflect all
This-
populations.
Making a reference.
Yeah.
I'll
Based
put the
on
link in.
all of our
So when
years of
possible or
clinical
when
experience,
applicable?
which we don't really get to. What are you doing now?
I like possible. Possible is very fuzzy, and this entire thing is very fuzzy.
That's why I think
Yeah,
we
that's
should read
It's
it.
a fuzzy recommendation because we're trying to keep it broad,
Right.
right? We're trying to keep it
The main
broad
change-
for lots of
Right.
coverage.
The main change will be us saying, yes, please cover automated cuffs.
And we're trying to make it as easy as possible, and we're trying to let them know what we think are the best options.
Yeah.
End of story. Yes?
Can we write that?
It's in the record now.
I still think there's a place for the line. I mean, what I heard a lot was that the XL cuffs are not easily on that list, so that they're
Well, he
something-
found. he
But
found-
then, it says when possible.
It says
so-
when possible, there was 3 on the
And we
list.
looked up the
There's
list.
21
There-
extra
Okay.
So he said there's 21 extra large on the list.
There's only 3 pregnancy ones and only 1 peds.
There may be like a rural pharmacy that only stocks one cuff or something.
Yeah.
Right, that's what, yeah.
Yes, our consultants.
Oh.
Are you The consultants are happy.
I also think that I would just say that with the amount of thought and discussion that's gone into this, the word recommend would be very reasonable and more consistent with other guidelines, but if everyone's happy with this, I don't specifically object, I just think it's worded strangely for a guideline recommendation.
Right, but we didn't look at the arm versus wrist.
Then why are we mentioning it? That's why I'm saying why. it's
Because our
there.
years of clinical experience tell us
The risk monitors suck.
that the risk monitors suck.
But they're on this list that we're then referring people to, so that's why.
Because in some people's cases, they may be the only option. So we're just trying to keep it all open.
Is it something we can ask for that review since it's coming up?
No,
I don't.
I'm sorry.
We have,
You're preferring conflict.
This is so far down the list of things we gotta do in the next
Yeah.
year and a half.
I was gonna say, we've got a big agenda today, so
Okay.
if we can get something that's pretty good and it's causing
And
problems.
broad and we're good. Our consultants are good, so we all good?
I'm good.
One more comment, are we sure there's no, we're gonna have to vet any conflicts of interest to this validated list? We haven't considered that there could be conflicts of interest in the development of that list, who developed it, who are they getting paid by, what are their conflicts of interest?
We have not done that analysis.
Right, so this is not my favorite, the yellow text is not my favorite for a couple of reasons. You guys can approve it with my dissent, that's fine. I just say that I think there are some potential issues there, because we haven't looked at them.
I do have information about who's on the advisory board, if that would be useful to you, and
But we're not gonna be able to back
No.
conflicts of
Yeah.
interest right
I
mean,
now, but
we-
that's great.
the
Is that,
FDA is on it.
is that
And they are
different than?
perfect and never have conflicts of
Yes.
interest, so
Okay.
there we go.
But I mean, is that different than how we use other, well,
I mean, like putting in a link to
expert group
NCCN,
guidelines?
putting in a link to the USPFTF.
And we use guideline recommendations from
thing.
specialty groups all the time, and that's the exact same thing.
But these
I hear-
are,
Automatic list, so it's not-
but
I
these
hear your
are-
objection.
these are a DME that could have conflict of interest
Yes.
because people are getting.
To be a member of a major board, that requires a conflict of interest evaluation check and disclosure to these are people recommending products. And so I don't know that it's,
Well, they've been through a validated process. It's a 14 person checklist, that's it.
Okay.
of
If you guys
things
are
that they had
happy
to
for
do.
it, bring it to a vote. I don't like it, but you guys can like it, that's okay.
All right.
You don't have to
Anybody-
sway me.
We appreciate and acknowledge your comments. Anybody want to make a motion?
Motion to approve as written.
Thank you.
I'll second.
Second from Chris, thank you. Everybody who approves, say aye in the room, write it in the, and we'll let all those not in favor also say nay.
I'm not in favor of the yellow text.
So
I'm
no,
an
duly noted.
aye, but I will put on the record that I have some concerns that are aligned with
You could make a no and then make another motion.
No, I mean, I'll vote yes, but I'll vote yes
With concerns.
with a concern that aligns with the concerns that Dr. Schnabel has raised, that we're kind of endorsing a list without really looking at the credibility of that resource.
Can we remove the list and just leave it as a validated device and then
We
follow
just
up
did a
on the
motion
rest?
and it was just approved.
Oh, I know, but I'm hearing what they're saying.
Okay, we got a lot to do.
But you could get.
Okay, I said yes.
I would count your yeses.
Yeah.
And I am a yes, but I'm putting on the record that I do have some of the similar concerns that Dr. Schnabel, and I understand her no vote.
Yeah, we can look into that and bring it back if we're concerned about that.
I think the preferred word helps.
Okay, all right, thank you so much. It passes. Woohoo, that took way more time. So, moving on.
Thank you for being.
Yes, thank you very much for your help. So moving to number 5, advisory panel reports. Ariel?
So the Oral Health Advisory Panel met. They recommended placement of the 2025 CPT codes. If anyone, there was a table included in your meeting packet. Does anyone want to pull any of the code placements for discussion? Okay.
We are on page 74 of your packet.
Thank you.
This is the public packet, but not the BBBS packet.
Right, so this is page 74 of
Why do we have the
660.
BBBS packet then?
You only have the private one? The 2400 page
The
one?
2400 page packet is only for view, we can't post that publicly, and we need to post public meeting materials, and so we follow that in the public meeting.
Okay.
Because that's what's available publicly.
Because the proprietary studies.
Right.
Okay,
Given I'm trying to follow along with those,
so
If
these
you
are
go
the
to our
CD
meetings page, you'll find it.
I'm just gonna move right there.
We can you page through, Liz, just,
That's not, this is not what they're using, yeah.
so, yeah, just page through so people can just kind of take a quick look. So this was what was recommended by the OHA dental group that gets together, and then OHAP also reviewed them and recommended them.
And we'll do that sheet in here. Can you mute, Mary Beth? We're getting noisy again.
And not hearing anyone wanting to discuss any of those codes, we can move on. The next item from OHAP was clarification of the frenectomy and frenotomy guidelines. These you have heard way too much about in the last few months. These are procedures for clipping the tissue that's either between the tongue and the bottom of the mouth or between the lip and the gum. The current guidelines really reference mostly dental codes, and we were asked to
Page 77.
Thank you. We were asked to include the CPT codes because ENTs, oral surgeons, et cetera, may use those codes. Additionally, there is one CPT code which is currently non-covered for incision of the labia frenum frenotomy that was recommended to be added to coverage, mainly because nobody knows what's a frenectomy, what's a frenotomy, and what's whatever. So they should. So the recommendation is to add several different CPT codes as well as a CDT code to the dental, covered dental line, and then modifying the guidelines, mainly putting in the CPT codes and noting that these procedures are included when they are used for cancer treatment or cleft palate lip repair. And then that would be for the frenulotomy, which is the lip type of change. And then for the tongue tie, it would be noted that the CPT code that is currently non-covered is not included on line 18 for tongue tie in the newborns. It's included on the uncovered line when used for tongue tie treatment, but on covered lines when used for cancer treatments. Questions?
Just thank you.
Okay. Any questions about that? I think those are our two oral health. We should probably vote on oral health and then we'll vote on genetics.
And the
Entertaining
buckle, the buckle one is in one of those codes? Okay. To get her procedures. Okay, maybe I'm not paying attention. Okay. Sorry, I'm trying to keep them all straight in my head on which one goes with which, but yeah.
I
it's
could
fine.
see it being used for like mouth cancer and things like.
Totally, yeah, I think that's probably why I haven't seen it, because we don't look at it. Okay, yeah.
Go recession surgery.
Entertain a motion to approve as presented
For the OHAP meeting materials.
of the OHAP meeting materials.
So moved.
Thank you, Adrian. Second?
Second.
Mary seconds, thank you. Everyone say aye in the room and please put your vote into the chat online. Aye.
Aye.
Thank you. Moving on to genetics advisory panel.
So the genetics advisory panel also met in October. You have several issues coming forward from them. The first is the yearly NCCN guideline update. Just to remind you, we have to refer to a specific document. NCCN tends to update their documents once or twice a year. So these are the updates. They actually changed the name of one of them as well, so there's a little more.
Can I just ask a quick question about that? And I appreciate that these links are live on the actual prioritized list. That's helpful. But often when you go there, they will give you the most updated version. So considering we're always doing medically necessary reviews and the fact that the guideline has been updated generally means they've expanded or added coverage, which we're always allowed to cover more, not less, than what was on the prioritized list. Doesn't it make sense as you review these to simply use whatever NCCN gives you as the most up-to-date guideline? It makes no sense to me clinically to try to go back to the previous guideline. Number one, you can't find them.
Yeah, so we're learning things in the benefit update project that affect that. And one is, yes, you can always cover more stuff. B, you can use external resources that are, in line with the definition of medical necessity and appropriateness. So we could move towards just referencing NCCN guidelines. The difficulty is if, for your DOJ colleagues, if there were a denial resulting from the use of a guideline and it wasn't clear what version was referenced by the person at the time, you could get into some trouble.
You just have to be clear what guideline you used.
I mean, you should be including that.
Right,
So
so you-
not the actual pages of
Right.
NCCN, that's what we typically do. I kind of cherry pick the parts that support whatever I'm talking about and include those, and it notes the version at the bottom of the page every time.
If that's the case, if you all, Darren, you have any concerns about that, or?
I just know what DOJ told me 15 years ago or
Right.
whatever, in terms of you're supposed to reference a specific version on the prioritized list. That's what they said at that time.
Yeah, I think the risk is it's not as binding if there's no specific version.
Clinically, of course, it makes no sense to go backwards if there's updated recommendations.
Right, and we had this actually affect somebody with the MRI of the breast a couple of years ago.
Mm-hmm.
And so if the commission wants to accept that risk, I think the commission can accept that risk.
Is there a concern if this has an older reference and making a decision, we use a newer reference? Is that problematic?
Yeah, that's what I'm talking about, is
Right.
that when you click on, I mean, I just did this yesterday.
Yeah.
When you click on, it takes you to their updated, because they update things and
With the DOJ, if we know which one we used, if it's newer than
Yeah,
on the list,
so-
is that a problem?
So here's what I do in that case, you should not reference the list, in that case, you should reference the medical necessity guideline and reference the NCCN guideline in support of that. HERC's endorsement is a
that
nice cherry on top.
I'm not even sure I would think of
It-
using that subtlety.
And that's gonna come into effect only when you have the hearing.
I mean, what if we said, when we put in these guidelines like this, or the most current version?
The most current version would not hold up in a hearing.
And the.
Again, it just makes no clinical sense.
Also,
And
the
we just-
actuarial office likes subversion because that's that
The,
defines what the benefit is.
we understand it makes no clinical sense, the difficulty is that it, like we had colleagues at the Med Conference talking about this recently, that some states don't have their guidelines or their policies in rule, they just have guidance. And that is not holding up in their hearings, and so we are ahead of them, which is the good news, but the bad news is, you know, we're a little bit stuck with this. This at least gives you a firm backstop in rule for the version that's cited in the guideline. The other guideline may still be valid, it's just gonna be a little longer path to say, well, you know, HERC endorsed the old version, the new version is accepted by the medical community, that's what says in medical necessity and appropriateness rules. You still get there.
Yes, and the actuarial staff wants us to reference a version because if a new version all of a sudden like lowers the age limit for MRIs or something that needs to be baked into capitation rates for CCOs, blah, blah, blah. So this is also what they want. So DOJ and actuarial like to reference this particular benefit at a particular point in time.
And some of that will change with the benefit update project, but yes.
And nonetheless, we can always cover more. Like when they dropped the age of colon cancer screening to
Yeah.
45, some of us went immediately to covering those,
And you just won't be,
recognizing the financial.
but you haven't been capitated for it, yeah.
Correct.
If we're using the update, that's gonna be mostly an approval, not a
Right.
denial, right? So it
Yeah,
probably won't
it's-
even go into the DOJ,
it's-
so then
it's-
it's a moot.
It's almost always, unless something's been proven dangerous, in which
Right.
case we shouldn't approve it in the first place.
Right.
So I think it's still the right thing to do, but I understand why we can't do it. So
Yeah.
thank you.
Staff would really prefer to just have like a generic without having to do this every
Specifically,
year.
I understand, okay.
Yeah, it's a lot.
Thank you for
Clarify.
allowing me to discuss that. Thank you.
Understanding all of your concerns, any questions about the actual changes being presented?
We're just talking about NCCN updates, right?
Yeah.
Okay.
Because we have a couple more things
Right,
from
that's why I'm
staff.
asking.
The first is testing of products of conception.
Page 89.
Thank you, for recurrent pregnancy loss. This came to us from a community OBGYN. She requested that we do genetic testing, fish testing with reflex microarray, which is a specific type of genetic test on products of conception to evaluate for genetic causes of miscarriage or molar pregnancy, which is a type of abnormal pregnancy. Currently, we cover these tests as diagnostic, but we have a prenatal testing guideline that limits them to things like amniocentesis. We also have a non-prenatal genetic testing guideline that has similar limits for some of these tests. For evidence, there was an expert guideline published in 2023 on diagnosis and treatment of recurrent pregnancy loss. And they noted that conventional karyotyping, it can be difficult with this type of pregnancy loss. They recommend using, and fish is limited because of the types of technicalities with probes and things like that. They recommend array CGH, which is a type of genetic testing. And they don't recommend at this time next generation sequencing, although they know it's being researched. Looking at expert guidelines, The expert guidelines indicate that after 2 or more pregnancy losses, it's reasonable to do this, but it doesn't offer information that would affect prognosis or treatment. ACOG recommends that you do chromosomal microarray when structural anomalies are noted on prenatal ultrasound. And it had some notations about how you should test in pregnancy. So most private insurance cover genetic testing after 2 or more pregnancy losses. Some are required to be consecutive, some just require you to have 2 or more losses. At GAP, the members were unanimous that genetic testing of products of conception is standard of care for the second or subsequent spontaneous abortion. They can find mutations that the parents could then be tested for to see if it's germline or just spontaneous in the product of conception. And HERC staff were directed to add an entry to the prenatal genetic testing guideline regarding genetic testing of products of conception, which we were directed to write, and we sent back to the GAP members, and they were in favor of the wording that the staff had come up with. So in summary, US and European guidelines note that this type of testing may be useful, although they note it doesn't really give you a lot of information or prognosis or treatment input. If testing is done, the recommendation is microarray CGH testing. The GAP members are unanimous that such testing is standard of care. The genetic tests are all diagnostic, so essentially we would need to alter our genetic testing guidelines. The recommendation is to add wording to the non-prenatal genetic testing guideline
Okay, there's a whole, yeah.
We'll talk about carrier screening in a minute, that's why it's purple and crossed out. It essentially would add a clause saying related to genetic testing for recurrent pregnancy loss, karyotyping FISH and array CGH testing of products of conception are covered for the second or subsequent spontaneous abortion or when fetal anomalies are present. The reason we're putting it in both the prenatal and the non-prenatal testing guideline is that when you are no longer pregnant and you're postpartum, there's a question about which guideline would apply.
Mm-hmm.
So, and technically this should be a non-prenatal genetic test because you're no longer pregnant. So anyway, that's why that wording is there. You'll see some purple wording that we'll discuss in a minute with a different issue. Does anyone have any questions or?
So all we're looking at on page of the public packet, page 100 is not the purple, we're looking on page 101.
Yeah.
At the blue, so in other words, E may or may not come out, F becomes the blue
Right,
on
and
page
it would,
101,
and it would
okay.
probably not be F anymore, it would be E if we take A.
Yeah, okay, so and then on page 103, big letter I.
Yeah.
Under prenatal genetic testing, okay. So let's talk about the blue for
Which is on the screen right there.
product of
Anyone who-
conception. Thoughts, comments? Val, our OB expert in the room.
It's a good thing to do.
I agree.
And it's saying 2 losses or fetal anomalies.
Second loss or more.
Or fetal okay.
Or
Yeah, so if you have a
fetal
very abnormal pregnancy,
non-survivable.
you could do the testing as a first loss.
Okay.
And also, I think that allows them to do the molar as the first.
Oh.
Yeah,
It should, right?
it should, yeah.
It should.
Because I'm fine with it, but none of the guidelines talk about just 1 fetal anomaly, right? They were
Yes,
talking about
with
2
a
losses.
fatal anomaly, but not with just one loss.
Oh, okay,
Make
okay.
it fetal anomaly
Okay.
instead of fetal anomalies. Fetal anomaly is present.
Well, so
Yeah.
it's either second or subsequent spontaneous loss or
When a fetal anomaly
when
is present.
Was.
You know what I mean?
Doesn't matter
Yeah.
which pregnancy.
Yeah, you need an A in there, because an H is fetal anomaly.
I don't know, that just makes it clear that it's not, we don't need multiple fetal anomalies to approve this, yeah.
Yeah, if it's a non-survivable fetal anomaly.
They're usually
One's good enough, yeah.
And it's okay.
Bad enough.
Okay, so, should we wait to vote till the second one, but we've changed this, so why don't we, just to be clear, let's take a motion and a second on the blue language. Anyone?
So
Thank you, Brian.
Second.
Second, Katie. All in favor, say aye. Aye, and put it in the chat, please.
Sorry, Liz, I was late.
Thank you, Mary. All right, let's go ahead and talk about the purple, please. No worries, just getting it written down. Okay, so the blue will change in both D1 and D17.
So the next one is what will now be blue, what was purple, which is carrier screening. This was brought to us by Max Kaiser. So carrier screening, just to remind you all, is looking at people who are either pregnant or potentially wanting to become pregnant or father a pregnancy to see if they have particular genetic mutations that can affect their reproductive decision making. So we previously had added wording recommending that the panel has to have so there's a ACGME, the American College of Medical Genetics, they have a guideline with tables of different genes, and we required it to have a frequency of more than 1 in 200. However, they felt this was too restrictive. There are a lot of panel tests that are using some genes that are a little more rare, but they still find those panels helpful. And they do note that the concerns that have been raised by HERC about variants of uncertain significance, which are mutations where we don't know if it's going to result in anything harmful or not, they don't report those in carrier screening, so that they felt that it would be, they would be very comfortable having more genes that are more rare. We also heard public testimony also saying that the 1 in 200 gene requirement is too restrictive and not based on current standard of care. So in summary, expanded carrier screening, the other question that came up is that we have a couple things in the guideline. We require the minimum testing required by ACOG, the American College of Obstetrics and Gynecology, and they wanted that to be basically you can do like the 1 in 200, all that stuff is kind of, you need to do at least the minimum set from ACOG. And then also they wanted wording about that these tests can't be unbundled, it has to be a single test. And reviewing this, staff found some CPT code errors that we wanted to correct. And then also staff are recommending that we split out carrier screening. It's currently in 2 guidelines. And it may be done on a pregnant person, it may be done on people contemplating pregnancy, which is why it's in both guidelines, but we thought it would just be less likely to cause errors down the line and making sure that the coverage is kept the same if we just break this out and make it its own guideline. So that would strike all of the carrier screening from the current prenatal and non-prenatal genetic testing guideline. And then we would make a new guideline for carrier screening that would include the current ones, that the screening of genetic carrier status has to have the minimum required by ACOG. And then expanded carrier screening is only covered, and then we would strike out the 1 in 200, and it would be the rest, except we would add some wording that the panel would have to be the minimum testing recommended by the ACOG guidelines. So like that's the floor. You can have more than that, but it has to have that as a minimum. And then we have a note about basically unbundling is not allowed.
what's the wording?
Where's this at? I'm sorry, Jessica, can you give a page number, please?
One moment. I believe we are coming up to
285.
page 294. We're leaving page 285.
No, we're still on carrier screening, so it's.
Oh, so
good.
we're still on page 285.
Okay, so you skipped it, I got it.
Oh,
So,
did I skip something?
well, it's just that we were talking about the purple and then now we're in a whole new spot.
Oh,
So
because
the
of
purple.
The other one was in the handout.
Yeah, so the purple means it's going away and we're putting it into its own separate guideline note.
Right.
So in so doing, it will cover both prenatal and non-pregnant peoples.
Exactly.
Thank you.
The ACOG recommendation, was it you should do the ones that are 1 in 200, or was it you should do at least the ones that are 1 in 200?
They believe they have a list. It's cystic fibrosis, Fragile X, spinal muscular atrophy, the Ashkenazi Jewish tests, and hemoglobinopathies. So we have those listed.
But didn't ACOG reference was it ACMG? Isn't that how we got there? Of using the genetic recommendation of greater than 1 in 200? Didn't ACOG say you should screen this? Or did we just,
So that's
Fine.
not considered expanded carrier screening, but the ACOG is considered carrier screening.
well, how did we get to using the ACMG greater than 1 in 200? I thought that was an ACOG thing saying, referring to that guy.
No, it was, there's an extensive article or
Right, yeah,
and we as the HERC went through, there's multiple tables.
Yeah.
And decided that we were concerned about some of the genes on the more rare genes, especially
oh,
the
we
brain.
did that.
Yeah, we did that.
Okay. I mean, the only concern I have is expanding is, yeah, right now the coding is pretty capped, right? It's 1,700, I think, for the code. But if we just kind of make a general recommendation and coding changes, or you can add on these codes, then that could greatly expand.
We
coverage.
can't add on the codes, if you page down just a little.
No, I know, this is a future worry. There's also the unbundling thing is a little bit complicated because there are panels that are less than 15 genes. And that code only codes for 15 genes, so you can still, I think technically, as far as I understand it, you can submit each individual code, or you can use the generic, I can't remember, it's 64999 or something like that. One of those, undetermined lab codes. So you can code it as just one code if it's under 15 genes, but that payment on those is really variable because it's whatever your contract is. That would be the only problem with the unbundling part, but back to the first part is I'd be concerned long-term if any of the coding changes or anything that we're covering a wider swath than we necessarily might contend to. And we limit lots of prenatal screening and.
Well, that's when you have to
Screening,
start
right.
looking at that's when the medical necessity review of individual panels comes in.
But if we're just saying we're gonna cover whatever because any gene is helpful, which is what GAP told us and what that guideline note would say, we wouldn't have anything to stand on. Because if there's a possibility that a rare gene could pop up that could have an effect, we'd be covering it. I don't think we take that
But the
tact
included
elsewhere.
genes result in conditions of an early onset in life, result in detrimental effects on quality of life. They have to have well-defined phenotypes.
I mean, we limit that, like, if you look at different states, I mean, it's infant screening, right? They all screen for different things when the infants are born, they make those.
That's different, that's newborn screening.
Right, but I'm talking
Completely
about,
different.
we limit those types of screening things in many other avenues. I'm always hesitant, especially with these genetic screenings, of just kind of opening the gates, because.
I guess my point is I don't think we're opening the gates.
Yeah, what I heard from the GAP members is just, there's a lot, they have to contract, or they don't have to, but they typically contract with a lab.
Yep.
That lab might have a gene, they might have a great panel that includes everything we want plus one gene that's 1 in 400, and then they can't use it because of our guideline.
Yeah, okay, so locally, we're a little more lenient than that, we're just kind of go like, if most of them are on there, great. If most of them kind of fit, great. But, so like there's a company that does 27, depending on the person, I think it's 20 to 22 meat, I think it's 20 the last time I looked, we cover that, but they also do a 400 gene panel, which we don't, because that's not even close. Right now, the cost is all the same, how coding goes, but I am a worrier, so this is yeah, and it's a big expanding thing where cost is huge, and I'm not sure there's always value in that. And that's why I get concerned when we kind of make very general statements about opening it to basically anything.
I don't think
Marianne Grave, your thoughts?
I'm just, no, I've been listening and I think it's been a great conversation and I just think this area is moving so quickly that I really appreciate the analysis on this. Yeah, I don't have any other comments.
Do you think the limitations listed in B are enough to be able to stem the tide or not?
I'm rereading through it just a second. I do, I think, I don't use the term fallout, but we rarely see notes come in that include genetic counseling. When we get this request, we often see that tests that appear to be, it's not clear to me how often this, or how this gets accessed, but patients appear to have some kind of direct entry where we just get information from the labs without a standard genetic counseling documentation, which should be required. So I do feel comfortable with the way this is drawn out.
Well, they always have to have a physician order. You can always use that one.
And lots of labs have built-in genetic testing. You have to reach out, but they say, we'll offer it pre and post.
Genetic counseling.
Sorry, yeah, I said counseling, yes.
Okay. Others, thoughts, concerns? So we're pulling these out, the others, we're making a whole nother guideline note.
And that's really just, I'm afraid we're gonna
No,
drop the ball with a change in one and not do a change in
yeah, no, I appreciate that. So it's, and I think you've made it clear enough, pregnant or patients contemplating pregnancy as well as the male reproductive partners. So pregnant patients or patient contemplating pregnancy.
Has anybody looked at the giant panels to see if they meet that criteria? Because sometimes they don't have, sometimes it's like future health risk. I don't know what they scan on those 400 ones because I haven't looked at all of them. I'm wondering if some of those bigger panels might actually not fit this either.
I don't think that's gonna fit B.
Yeah, I'm wondering.
You just
And then
gotta
I'm
look
not
at
sure
it.
if we're really solving anything. If the bigger ones that they want, that they're talking about, that get denied because they don't fit the 1 in 200, do they
Well,
all?
they will not fit,
I
I don't think they're gonna fit B
Okay.
1
That's what I'm
through
asking, I
6.
don't know, I haven't looked at the giant ones.
I don't,
think they're doing the giant ones, I think.
oh, they're getting requested.
Yeah, I see them pretty frequently. That's why I know, that's why I can name how many they are off the top of my head, right? That's not because I see them every once in a while. Yeah, I see them
Any other
regularly.
thoughts, concerns? Yes, please, Val.
Currently, you've referenced only ACOG Bulletin 690, the 202/2023 carrier screening in the age of genomic medicine. But there is a primary bulletin that was reaffirmed in 2020 that is reaffirmed later than that, earlier than that. So it's 691, reaffirmed in 2020. That's carrier screening for genetic conditions, and ACOG cross-references these. So I think maybe you should reference both of them. The 691 is the one that has the primary list, everything from Fragile X to Tay-Sachs.
So we could take that as a friendly amendment that staff will look for and reference the second ACOG bulletin.
Was that the first?
Yeah, first 2020.
They're joint, they kind of go together.
I think that makes great sense, thank you. Gives us the ability to go back to the initial source, which is helpful.
If you are okay with trusting staff to just do that, we don't have to wordsmith that. Or I guess,
No.
we sort of have wordsmithed it.
Yeah, it's fine.
Okay.
In my opinion. Others online, thoughts?
It feels like it's a good change to efficiency. I like that we wouldn't bill it and that the populations are grouped.
Yeah, me too. All right, I'll entertain a motion to approve with the staff recommendations and friendly amendment.
Do we need to talk about the unbundling part?
Nope.
Okay, so you want them to do the generic code for under 15?
I do.
That's fine, I just wanna make sure that the,
Anyone?
Is there, just to address Max's concern, because I appreciate the bigger perspective, and I do think it's a changing topic. Is this one of the ones we could just kind of put on the monitoring so that then, since you are seeing them frequently, Max, it sounds like something we need to keep an eye on?
It's on the monitoring list.
Okay,
Everybody's
then we have some
monitoring
controls,
it.
yeah. Okay, I'll motion to approve.
Thank you, Chris. Second, from Brian, thank you. All in favor, say aye in the room and online. Aye.
Aye.
I nay, just 'cause
Mary?
I wanna look more into it before I jump on.
Max
Max.
Kaiser voted nay for the record.
For the record. Thank you.
All right, one more topic. We'll take a very short break because we have a lot of codes to go through. So this is whole exome sequencing for prenatal indications. This was actually a topic that was brought up by GAP members. Whole exome sequencing is where you look at all of the DNA that codes for genes that are actually used in the cell. There is an ACMG statement from 2020 that exome sequencing may be
Page
considered.
294.
Thank you. Exome sequencing may be considered for a fetus with ultrasound anomalies when standard types of tests have not yielded diagnosis. This is not necessarily, so Aetna doesn't cover it, Cigna does. Those were the two that I was able to find written out guidelines. GAP members all supported adding prenatal whole exome sequencing when karyotyping and microarray testing is negative and they see fetal anomalies on ultrasound imaging. So ACMG supports this whole exome sequencing in that situation. There's some coverage differences in private payers. Based on the ACMG guidelines, staff is recommending making changes. So this would add a clause to the prenatal genetic testing guidelines saying whole exome sequencing is only when standard genetic testing, chromosomal microarray analysis and/or karyotype of the fetus has been performed and it's uninformative and the fetus has one or more fetal anomalies seen on imaging. Just as a side note, the world is moving toward whole exome sequencing for everything.
Really?
Yep.
Why do you want that much information?
It's not
They're
that
doing it.
expensive, right?
They're actually, that's what they're doing, and they just report the genes that you paid for. And then they're selling the extra genes to biotech.
Yeah,
My usual rant.
I know. Believe me.
Any questions or concerns about this?
Yes.
Yes?
Well, not any questions, and some concerns.
It's a great
Hi, this is
conversation.
Mary, I have just a comment,
Yeah, Mary, go ahead.
and I know this is not within the realm of what we're doing now, but it does appear that, just because the field has changed so much, that the fee schedule payments are really out of date. The cost has come down significantly, this has become more and more available. And that has been passed on in the past, but we're paying about $10,000 for a single standard test per fee schedule. The commercial rate's about $2,400. So
Yeah,
it's just.
I'm sorry, we can't address fee schedules here.
So Mary, yeah, Mary, we can't address fee schedules here, but there's a guy in the room who can take that information back, Darren Kaufman, and think about taking that, well, you know who to take it to. Take it to somebody who can address the fee schedule issues.
And staff can forward
Yeah.
that as well.
Thanks, Mary, it's a good point.
Thank you.
All right. So other questions, comments on, I'm back to where are we at? Page 298. We're taking rid of all of the purple. Whole exome when only standard diagnostic chromosome microarray and karyotype has been performed and is uninformative, and the fetus has one or more fetal anomalies seen on imaging.
Relatively rare, that sequence too, right?
Yeah,
There's not really another option,
there it
once
is.
we're there.
And you don't have to repeat the amnio, they just use the same material.
Oh, that's nice.
Unless there's insufficient.
Of course, yeah.
Yeah.
All right, so Val, you're okay?
Yeah, we're gonna be doing this on everybody for everything.
Lord.
But you can stick your thumb in the deck, yeah.
While the water cascades around me is what you're saying?
So we really need to be moving along, we're
So-
way behind.
Yeah.
And we can do.
All right, so motion to approve. Thank you, Katie. Second, Brian, all in favor say aye.
Aye.
Alright. We wanna take a 10-minute break before we
There's
start?
there's one more genetic, it's the 2025 CPT codes in relation to genetics.
Oh, we'll talk about that with this
CPT,
Oh, do they have a separate
There's
issue?
specific gap report.
sorry.
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 Oh, I see it
Here.
here.
Yeah. But a new way of looking at
Page
genes,
81.
genetic counselors.
Oh, sorry, let me grab that. Where is that? Did I just lump it with?
Yeah, you skipped over it, started going to other genetic gap stuff, but this is the first in the gap report.
I did, I totally skipped it, I apologize.
Back to page 81, please.
Somebody else has it open, can somebody, you do it?
It's not me, I have a copy open.
Jessica, if you have that open, could you close it?
You can also follow along on the
Oh,
screen.
okay. I actually,
I seem to be moving this.
I got it
forward.
Okay. So there were a couple of new genetic related tests. One is for optical genome mapping, which is a new technology for looking at genes. We did an evidence review and GAP agreed with the staff that this is not ready for prime time. They had me reach out to Knight Labs to see if there was any newer and updated, and the Knight Lab folks have also agreed that it's not ready for prime time. So this would be adding it to guideline note 173. And then medical genetic counseling services, we should add that to the diagnostic procedures file. This is mainly a thing because now genetic counselors are, and many states, including Oregon, have their own licenses, so they need a code. And then there is the psychiatric drug metabolism. These are PLA codes, the U codes. We don't normally review these, but we have a guideline specifically saying we don't cover psychiatric drug metabolisms, and so adding those codes to that ensuring guideline note 173 for completeness. Thank you for catching that, Liz.
Any discussion? Seems pretty straightforward.
Motion to approve.
Thank you. Second, all in favor? Aye.
So let's try to take a very short break. We have a lot of codes and we have to get through them, and we also have, so at this point, I am recommending that everything that's not new codes we table till January. So there is all the new discussion and planning and review items we can discuss in January unless we get through the codes really fast.
Which we're going to.
Okay, we'll start with the codes.
Okay, so let's take a break for 10 minutes.
Okay, not 11, 10.
Preferably.
Be back at 10, 11.
I only respond to Gavin.
Good man.
You're such a brat. I miss you.
I have resumed recording.
Alright, folks, hold on, I'm just pulling up some of the CPT code things.
Oh, Holly Joe just left the room.
We can start without Brian.
Oh, Brian's still, okay, Brian stepped out, but we're gonna go ahead and get started and catch him up with these.
Yeah, so the first item in the CPT codes is the straightforward items. Does anyone want to pull any of those codes out for further discussion? It was, Jessica, can you give us the page number?
303.
Thank you, Jason.
If anyone wants to pull a code out, I'm happy to do so. If not, the next item is
310.
straightforward, and these are codes that they just need something else done. They don't really need an evidence review. So fascial pain blocks just need a change to an ancillary guideline. Digital computerized ophthalmic imaging. There was a couple of extra codes that need to be added to diagnostic to kind of be along with that. Any questions about either of those? Straightforward, just need a few extra change type things. And we can move to CAR T therapy. This is a form of cancer therapy where they take out your own T cells and modify them in some mysterious way and give it back to you. There are currently 6 FDA approved CAR T therapies. We have consulted with our PNT colleagues. We cover them according to FDA criteria, et cetera. ASCO, and then NCCN also recommends them for, they mention them in their NCCN guidelines. So the recommendation is to add so the drugs are ancillary. These are the codes that would be used in the, like getting the cells or putting them back in. So making those ancillary as well to go with the drugs. And then saying that they are on, friendly amendment, it says these lines, they should just say covered, because I think that was when I had options. T cell therapy is covered when the treatment is an FDA approved drug and the patient has a primary cancer diagnosis made by a treating oncologist and the patient conditions are met.
Okay, hang on a second. So when the treatment is FDA approved, what about the indication is FDA approved for this treatment? Is that what we're trying to say there?
It says according to an FDA indication. The third line of that.
According to an FDA indication, okay. Because I've gotten requests for everything for this. Absolutely everything.
Are PNT covering CAR T therapy now?
For the FDA approved indications.
Because the PrEP codes and administration codes are all category 3 codes, which aren't covered right now. There's an OAR that we don't cover category 3
Are they
codes.
T codes?
Yeah.
Okay, we should check into that.
I mean, it's gonna change.
We should be covering things associated with FDA approved drug treatments, because.
That's why I was confused. It's gonna change because the codes are changing from the category 3 codes to.
Oh, okay.
Yeah,
So with this guideline note, it'll fix it?
I think so.
That's what I was asking right
But we
now.
should adjust it going forward, because there's gonna be more of these, right?
Well, we need to find out if there is still T codes or if they just resolved, if they just changed into
Okay,
different codes.
We'll take that away.
I think they have to.
Yeah,
My understanding of category 3 codes. Yeah.
T codes become.
So I think this was
other
fine,
codes
this will
usually.
fix it. Right now, I understand it's not because the ancillary, or the associated ones aren't.
But there's like 6 things that this is FDA approved to treat right now. And we don't want to list them because they'll add things.
And they've already taken one away.
I think there's 1 or 2 that I know of that at least are coming pretty quick.
I don't remember.
Okay, is the proposal workable for today?
Yep.
Yeah.
Okay, let's keep moving.
Hi, this is
A lot to
this
get
is Chris. I don't know if this is the right time. I don't know if I need to do this or not, but I just want to disclose a potential conflict of interest because I do have some published work under T cell therapy. It's older, but it works on. So I don't know if I need to disclose that or not. There's no conflict financially. I just
Thank you
want
for
to put that out
bringing
there.
that up.
Yeah, thank you for doing that, yes.
Thank you.
All right, and then the next couple of codes are for newer treatments for prostate issues. I've run these by our very own Brian Duty, who agrees. So the first one is high intensity directional ultrasound. It's basically a way to use energy to kind of shrink prostate tissue. It's only been studied in a few small cohort studies.
Page
It's not
315.
Thank you. It's not mentioned in expert guidelines as a treatment option, and the recommendation is guideline note 173.
Okay.
And then also in guideline note 145, which is a treatment of benign prostate issues, we would add wording. And you'll see purple and blue wording because there's two prostate issues, both of which we're recommending non-coverage. So the second prostate new treatment is ischemic remodeling. This is another procedure that uses energy to shrink enlarged prostate. It also
322.
It has one RCT and a couple of cohort studies. The RCT was small with 150 patients. It did show clinically significant improvement in the IPSS score, which is a way to rate urinary issues from prostates, compared to sham. However, it was really notable. There was a very high responder rate to the sham procedure of 60%. And then the randomized controlled trial did not show any significant improvement in quality of life. NICE has also reviewed this and did not find sufficient evidence to cover it. Private payers are feeling that it's experimental, although Aetna is covering it. The staff conclusion is that the literature is sparse on the efficacy and harms, and at this point it's experimental and added to guideline note 173 and then wording into the benign prostate LUTS guideline. Right, moving on. Thyroid radiofrequency ablation. This is using energy to destroy part of your prostate for either a benign nodule or in some cases for thyroid cancers. There was a systematic review and meta-analysis, and we also looked at major guidelines from NCCN and NICE. And the conclusion basically is that the evidence base consists, for benign thyroid nodules, the evidence base consists of cohort studies. However, NICE reviewed this and found sufficient evidence to support the use of RFA for this indication, and expert societies are also supporting their use. However, insurers are mixed on their coverage for RFA for benign thyroid nodules. An RFA for treatment of various types of thyroid cancer is an option in NCCN and is being covered by private payers. So the recommendation is to add the codes to the lines for benign thyroid nodules and thyroid cancer, and then add a new guideline to the thyroid nodule line, saying that it's only included when the nodule is confirmed to be as benign with FNA and there's compressive symptoms, changes in voice, dysphagia, pain, etc.
That is on page 337.
And NICE looked at the same data we looked at, right? So you don't usually with cohort studies, right?
They may
recommend things.
Let me look at what NICE said.
Because they're all, I had to look into this a while ago, they were all pretty small and they were all, almost all in populations of not the US, usually Asian countries, but Italy was the other one, if I remember right.
There were 20 studies with 1,406 benign thyroid nodules, all showed a significant decrease in the size of the nodule. Their pooled meta-analysis demonstrated significant difference in nodule volume, symptom score, etc.
I think the only drawback to it was a higher rate of repeats versus excision, but obviously excision's a little more invasive.
Yeah, and we would still cover the excision, so I guess it would be a decision between the surgeon and the patient.
Right, but then it comes down to if there's enough repeats, does it actually be beneficial, et cetera, and I'm sure that doesn't exist. Okay. After looking into it, I was a little surprised about the NICE recommendation because of that. They did a meta-analysis, so okay, makes more sense, thanks.
Any other concerns or anyone else want to have anything they want to discuss with us? All right, let me just save that. And then we are moving on to intracranial MRGFUS. MRGFUS is a magnetic resonant imaging guided high intensity focused ultrasound. So using an MRI And then you focus ultrasound energy to destroy tissue in the brain. It's approved to treat medically refractory and disabling essential tremor, which is when you have shaking of an extremity without other cause. There is a systematic review and an Ontario technology review and a NICE review for essential tremor that all thought that it was useful. And then for Parkinson's disease, it's a little bit more murky. I consulted OHSU neurosurgery and we had 2 of the neurosurgeons comment on it. And they assisted in making the guideline. They recommended coverage for essential tremor and not Parkinson's disease, which was consistent with what staff found on the evidence review. So essentially this has very limited evidence for treatment of essential tremor. It's basically 1 RCT and a number of small observational studies. There's no studies comparing this procedure to deep brain stimulation or other surgical procedures that we currently cover. And then, so this would again go in that category. NICE looked at this and felt that it was experimental. However, another highly evidence-based trusted source, the Ontario Health Assessment, found adequate support. And the expert American guideline, if you can't undergo DBS or you don't get benefit with DBS, this is sort of a rescue procedure. Medicare and private insurance is covering this for essential tremor in a select population. So based on the Ontario Technology Assessment as well as our local experts, we're recommending coverage for essential tremor with a guideline. The evidence for Parkinson's disease is even smaller. It's basically just cohort and case series, and none of the consulted expert sources or experts recommended coverage for that indication. So the recommendation is to add the new CPT code to the dystonia line and add a new guideline saying that this is covered when you have had an adequate trial of medication therapy or you're not able to tolerate the medicine, your tremor is moderate or severe as defined by a standard rating scale. It affects your ability to do activities of daily living as defined by a nationally accepted clinical measure. And you're not a candidate for DBS, you've failed DBS or have failed deep brain stimulation. Any comments, questions, concerns about that?
This is Chris. I didn't see that it has a lot of adverse side effects. It's like, it doesn't look like it's a high risk for danger.
Anytime you're doing a procedure on the brain, there's an inherent level of risk, but it seems like it's at least as safe as currently covered therapies.
Thanks.
Any other questions? The next topic is iris prostheses. So if you have either were born without or had trauma or some disease that required removal.
Page 508.
That required removal of the colored portion of the eye, the iris, they have this prosthetic. Currently there is a HIC code that we have in guideline note 173. There was a systematic review in 2023 and a NICE review that's older that basically found that there's very limited evidence that it improves vision or any other symptom. And there's a pretty concerningly high rate of complications. NICE considers them experimental and all private payers surveyed consider them experimental. So the recommendation is to add them to guideline, well, this will not be our excluded guideline, but the guideline note 173 and with the HIC code that's currently there and then update the date of last review. Questions, concerns? Then the next one is gene expression profile for kidney transplant rejection. This is a test called TrueGraph. It's a proprietary lab test which gives you a score, sort of a binary, a yes, no, on whether you are at risk of having a kidney rejection. And it's marketed as a way to avoid kidney biopsy. because if your score is low, then you wouldn't need a routine kidney biopsy. There was a retrospective analysis of 192 patients, which is the only study I could find looking at this. And the expert guidelines on kidney transplant recommend just basically doing monitoring of normal tests that we always do, looking at creatinine and looking for proteinuria. And then if there is a concern based on routine lab testing, then the biopsy of the transplanted kidney. You can also do kidney ultrasounds. So the staff recommendation is that this appears to be experimental. It's not routine part of post-kidney transplant monitoring, and private payers are considering it experimental. Of note, CMS is considering this to be a biomarker, and because of that, they are probably going to cover it. But I'm recommending it for guideline note 173. Questions, concerns about that? And then we have biomarker testing for neurodegenerative diseases. If any of you are in primary care, and this is coming toward you. So there are 5 new codes looking at amyloid, beta amyloid proteins. That's what the A beta, it's beta amyloid. There's all these things looking at ratios. So there's a couple different types of beta amyloid, 40 and 42. There's ratios, then you get neurofilament light chain and phosphorylated tau and tau total. These are all proteins that you can find in the CSF or in the blood that can indicate that you have the amyloid tangles in the brain that can lead to or cause Alzheimer's disease. Alzheimer's disease is one of the most common forms of dementia. And there have been and will be medications to try to prevent progression of Alzheimer's disease in people who appear to have risk. They are all requiring, the previous drugs and probably the future drugs will require an amyloid PET scan to confirm that you do have Alzheimer's, because these drugs have been shown to cause intracranial hemorrhage and other bad things. So you only want to give it to people who could benefit because they actually have beta amyloids. And tau proteins, beta amyloid, they're all part of these tangles. Currently, if you are concerned you have Alzheimer's disease, the gold standard is autopsy, which is obviously not going to be helpful during lifetime. So if you want to treat somebody during lifetime, the gold standard is these amyloid PET scans, as well as clinical, you need to have clinical concern and then confirm it with the amyloid PET scan. So some people will have a ton of tangles on amyloid PET scan and be clinically normal, and those people may or may not ever develop Alzheimer's disease. Probably if we all live long enough, we will have tangles. So if you are wanting to treat people with drugs, aducanumab and lecanemab are currently being developed. They're in the pipeline for being approved to treat Alzheimer's. You would need to have a confirmatory test, which currently would be the amyloid PET scan, in people who have a clinical picture that makes it suspicious for Alzheimer's. So this is a really rapidly developing field. There was a expert guideline that was published about a month ago from the Global CEO Initiative, and that basically was trying to set some guidelines about what these tests, so what this field is going to look like. Currently, some of these drugs, not only you can have the beta amyloid PET scan, but you can also have evidence of these proteins in your CSF to qualify for these drugs. There are rapidly moving developments toward blood tests. These blood tests are probably going to be marketed to primary care as well as neurology. And it's probably going to come down the pike that it's marketed as, if you have concerns about your future risk of developing Alzheimer's, or you're having some memory issues, am I developing Alzheimer's? You know, should I get these blood tests or not? That is definitely where the field is rapidly trying to move. So the CEO initiative basically was saying, you should only cover these blood tests if they are at least as good as the amyloid PET or the CSF tests, which is a sensitivity and a specificity of greater than 90%. Because most people, as they age, develop these proteins. There are studies looking at cohorts which show that they just increase with age and with comorbidities like hypertension. So, what do these tests all mean? And so there is, as you can see, a lot of stuff that's just been published in the last few months, even looking at the accuracy and the use for these. The Alzheimer's Association work group published a guideline in the last couple of months, and they recommend that to diagnose Alzheimer's, you do an amyloid PET or you do CSF testing and you get these different things, or quote unquote accurate plasma assays, where accurate is defined as the accuracy equivalent to approved CSF assays. And so beta amyloid as well as these neurofilament kinds of tests. There are lots of private payers that are rapidly developing criteria as well. I consulted with our P&T colleagues. So they are noting that the newer drugs coming out will allow CSF, beta amyloid, and phosphorylated tau testing in lieu of the PET scans that we currently cover. And there is new medication, which is in clinical phase 2 trials, blarcamesine, which is using blood tests for biomarkers to see if you would qualify, and they are using the blood markers to monitor the effectiveness of the medication. So this is, that drug is not FDA approved, it's not being considered yet, but just giving you situational awareness. So plasma and CSF biomarkers are rapidly coming forward. Currently the standard is clinical evaluation confirmed by an amyloid PET test. However, some of these drugs are now allowing CSF, so doing a spinal tap and finding various ratios of these proteins are being used as criteria for some of these medications, and those are being covered by private payers. And P&T recommends that we cover them because of their PA criteria. The blood test is currently only done in research settings. There's a lot of concern by experts about these tests and their use. And staff at this point is recommending that we not cover the serum tests. This obviously would be, as a rapidly developing field, we may be addressing this very soon. So the staff recommendation is to add the 5 new CPT codes to the diagnostic procedure file with a new diagnostic guideline that testing for these, including the PLA codes and the CPT codes, is only covered when the patient clinically has mild cognitive impairment, they're 55 or older, they're being evaluated for disease-modifying therapy, one of these drugs, and the test is done on CSF. So this will prevent it being used as looking for anybody. They need to be clinically suspicious. They need to be going down the path to get a drug, and it has to be CSF at this point.
And we cover the drugs currently.
Yeah, I would have probably put stricter criteria for the CSF, but P&T asked that we have it open because that is the FDA labeling for 2 of the currently approved drugs.
Yeah. Okay.
Why mild cognitive impairment? What if somebody had moderate cognitive impairment?
They're not a candidate at this point for the disease modifying
Drugs
therapy.
aren't approved.
It's too late.
Oh, I see.
It's too
Okay.
late, yeah. Disease progression.
Yeah. If you're severely along, you should not be getting
Can I get this
drugs.
now? Start now.
The intent will be there. But
Seriously,
there are.
these drugs are an entire can of worms.
Yeah. Yes. And I was terrified reading the literature. They are doing testing in primary care offices.
For the first drug.
And they shockingly discovered that people who are seen in neurology clinic, the neurologists are better at diagnosing dementia. Because you only get the people that the primary care person already said that probably has dementia.
Okay, is there any controversy about this?
No.
Okay, thank you.
Yeah.
Let's keep
Is
it.
disease modifying therapy specific enough to know that it's referring to the new drug, so we aren't risking people thinking like Denacil is a disease modifying therapy?
Do we want to?
I'm just wondering if disease modifying therapy is specific enough to know that the intention of this is restricted to these newer agents.
I mean, should we, because in some of the other ones, there's that like genetic test that we say we only cover it for this one drug. Do we want to say, it's covered for FDA? I can't remember the wording, but essentially if the drug requires it or it's part of the.
Adrian, make a suggestion of the wording, please. You're talking about 3?
Yeah, I'm just like some of the therapies that would be used more for like
So we could
symptomatic.
say disease modifying therapy with FDA labeling requiring
Yeah.
CSF or a beta amyloid, something like that.
That would help, that would be helpful, that would help you narrow and not, because we know what we're talking about, but the space is just changing for so long that.
You're right,
Requiring what?
Requiring biomarker testing.
Yeah.
whatever Adrian says.
Okay, so what we would say is that the patient is being evaluated for disease modifying therapy with FDA labeling requiring biomarker testing. You could do a PET, I don't know if PET amyloid is biomarker testing or PET amyloid.
Or not and.
That answered my question. I was wondering where the PET came up in this guideline.
Yeah, so we have a separate guideline about amyloid PET. Because it's not a biomarker. It is a test.
Okay, so we want to
That makes sense.
cover the biomarker if the drug requires that amyloid?
So
Yeah, that's what
the wording in yellow, is that sufficient, Adrian, particularly?
I think so, I'm just trying to figure out like how do you not, if somebody's reading this in a couple of years, realize like some of these old oral agents that are not particularly effective in treating Alzheimer's disease, a disease modifying is being used in this context for a very specific class of medications. Like not everything that you could use.
And that the patient has had biomarker testing or PET amyloid testing, which would be FDA required in only the biologics.
Yeah, it's a way to back into these newer biologics.
Yeah,
I think it's fine, or at least.
So right now
I think
it's
I get that.
only used for donanemab, but it's also gonna be used for blarcamesine.
Mm-hmm.
Yeah.
And if we
Is this
say, but
weird?
they took one or two of the drugs off the market.
It's Aduhelm is now gone, yeah.
Yeah.
Lecanemab.
So this language works?
Is there any, like, is this fine that testing for beta amyloid is covered, blah, 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 when the patient is being evaluated with PET amyloid testing? That's all fine.
Wait, why do we need the PET?
Right, that's one thing, I don't think we need that PET comment on it.
No, we don't need the PET comment because,
Yeah.
if the drug requires PET, we do PET, right? So we don't need the or.
We just wanna do the
The
CSF
biomarker
testing
testing.
if it requires CSF,
Okay,
if the
right.
treatment requires CSF testing.
The PET is a separate guideline.
I think
Yeah, so this will limit to what P&T was saying.
Which is what we're all.
They need to have this testing for one drug because of the FDA labeling.
Thank
I'm
you.
sure that HERC will be readdressing this space sometime in the near future.
Took 2 months.
March.
Exactly. Okay,
I
Can we move
actually
on?
feel it's very scary.
Mhm.
But anyway. Okay, transcranial Doppler studies. So these are different tests where you are looking at how blood flows through the brain. We currently list similar procedures on guideline note 173.
Page 543.
But that was last reviewed, going back to some comment earlier, in 2004, so 20 years ago. This is now the accepted test. The American Academy of Neurology had a guideline, they retired it in 2018, recognizing that it was standard of care. Everybody does this as standard of care. It is standard of care for various different types of things. It's a pretty simple test with no adverse effects, it's inexpensive, and we're recommending making the current new codes as well as the currently existing codes all diagnostic and striking the entry from guideline note 173. Questions, concerns? I heard one, I'm fine.
Anybody else? It's all good.
Yeah,
good,
it's
good.
fine.
Yeah, okay, thank you.
And then the AMA in their ultimate wisdom have issued a large series of codes, all for audio video visits. And then there's also a brief communication technology-based virtual check-in. We currently have all of
Page 547.
So we currently have HCPCS codes for virtual check-ins, telephone visit codes, office visit codes, everything already covered, and we have a guideline about telehealth. CMS has determined that they're not going to open any of these codes, except the telehealth, and that's because they don't agree with the relative value units assigned to them by the RUC at the AMA. CMS can assign the HCPCS values, the AMA assigns the relative value units. So they are, and if CMS does not open a code, we have no standard to open a code. We don't know what to pay for it, so we can't open it either. So previously the HERC has and continues to like virtual and telephonic visits when appropriate. However, if CMS continues to say that they're not going to open these codes, we are unable to open them. I am recommending that we put these codes on all the lines on the list, because if they are opened, that would, or not all the lines with E&M codes, and modify our telephonic guideline to include this code range, as well as a change. The one code that CMS agreed on was the check-in, and so they're removing their HCPCS code to replace it with the CPT code. But these codes, other than the telephonic check-in, will not be available. They won't be in the.
For Medicare.
Right, we do 70% of Medicare, so I was told if we don't open, if
Oh, we
Medicare
can't.
doesn't
And
open them,
Medicaid,
we
yeah.
can't.
They won't be on the fee schedule, but CCOs can use them.
Yes.
And if they become available.
Yes, so if you're using them like for another line of service, and you wanna open them for Medicaid. Okay.
Got it, thank you. We'll pay them something.
All right, so that is the end of the CPT code agenda. Should we vote on all of them?
Did we get through?
Haven't gotten to the HCPCS, that's a whole.
Okay,
new
so
can of worms.
CPT codes, I'd entertain a motion to approve
Motion to approve as amended.
as amended. Great, yes, indeed, thank you. Second on Brian, everybody say aye or put your vote in the chat, please.
Aye.
So now we're gonna go to the packet, or the handout mini packet that you all received on Tuesday. This is the January HCPCS codes, and I apologize that you didn't have more time to review them, but staff also didn't have a lot of time to review them.
Sorry, we got these on Friday, I think. So kudos to Ariel.
Yeah.
Page 19 of the handout.
So the first item is our straightforward. These are all ones that either are similar to existing codes or CMS had already published in their minutes about the codes, like what their intents were. Anyone want to pull out any of the codes on that consent table? Then we have some codes requiring that I didn't do an evidence review, they just needed something else done. So there's 3D imaging, there's a new code.
27.
New code for that. We don't cover 3D imaging. HERC has always considered it part of the underlying imaging. We don't reimburse the 3D part separately. So adding that code to guideline note 173 and updating the guideline note 173 and treat date. Then there are two new codes one is for standardized evidence-based risk factor assessment and ASCBD. This is really commonly done in primary care. You look at various various test results and give someone a risk score for heart disease, and you use that to recommend things like statin therapy. And then there's also a code for cardiovascular disease risk management. CMS is releasing these because of their, they had a pilot program called the Million Hearts Model and found that these were very useful for improving health. And there is a related code, a Z code for screening for cardiovascular disorders that we have on both of our covered and our uncovered prevention lines. Staff recommends adding these two new codes to the covered prevention line. And then the reason it's here is whether or not the management code should be on a couple of lines for hypertension, dyslipidemia, or whether just having it on the prevention line would be sufficient. So the management code is management of cholesterol, smoking, and blood pressure management according to the CMS definition of this code.
Included in the management line.
Okay.
Seems like this is Chris. It seems like if it's a prevention service, then that's more encompassing and you only have to list it in one place for multiple reasons versus once you get into management, you're getting more narrow into why.
But it's a management code of specific conditions on line 75.
Oh, okay.
And line 219.
So it's already there.
Yeah, so the first code is just looking at someone's risk factors. So that is a preventive service. That should be on line 3. The second one could be a preventive service because you may be talking about diet, exercise, aspirin use. That would be line 3. But it may be used in terms of management of hypertension and dyslipidemia. So I think adding to those two lines would be appropriate.
So it'd be on both lines.
Yeah, it'd be on both lines.
Okay.
And all
yeah,
three
makes
lines
sense.
actually.
But if it gets billed and the primary is diabetes, it's gonna get denied.
Well, that's fine, they should use a different code.
Yeah.
They should use a different code.
Yeah.
Okay.
That's not what CMS has defined this code to be. Okay. Pulmonary artery pressure monitoring devices. These are cardiomems. This is a code used for the replacement system, but we don't cover the initial system, so adding it to the guideline note 173 entry. Then there is safety planning intervention. This may be old. So this is something that is highly recommended. It's basically suicide prevention planning. So if somebody is saying that they have suicidal ideation or they're at risk for substance overdose, this can be used especially for the behavioral health folks to come up with a safety plan. So suicidal ideation is diagnostic, major depressions on a couple of lines, substance use disorders on the substance use disorder line. So the recommendation that we actually have the staff really would recommend is diagnostic because it should be just used for anything where there is risk. If you are concerned, we could limit it to a few lines, but put down all lines with the inputs. Any concern about making a diagnostic? It would just pay with any diagnosis then.
I don't think so.
I don't think so either. I think it's a good thing. We don't want people to have to worry about coding. They're talking about safety.
Right.
Okay, so hearing diagnostic?
Yeah.
And then the next code is for stereotactic body radiation therapy. And we have a whole guideline about this. And the staff recommendation is to place the new code on the lines that have the current stereotactic body radiation therapy, and then modify the guideline, adding the new HCPC codes. And as part of this, I noticed that the two lines, only one of the 3 lines of the codes is referenced in the guidelines. We need to add the other 2 lines. And then the last one is historical trauma services for Indigenous persons. This is part of the Not Invisible Act. We have consulted with our tribal member, And these are meant basically for tracking, to see what services are being provided under this act. And so the recommendation is all lines with psychotherapy. And there'll probably be secondary codes, that's some monitoring. Questions, concerns about that? Great, then we are moving on to, if that was the next document.
Renal
Renal artery denervation.
Page 32.
So this is a procedure, so the kidneys are in charge of the blood pressure. There is sort of a theory that if you ablate the renal nerve going to the renal arteries, that you can treat drug-resistant hypertension. It currently has T codes, those temporary codes that we can't pay for. There's a Cochrane review, it's a couple years old, it was a well-done systematic review of 15 studies that found low certainty evidence that it does not improve any outcomes. It might improve some short-term outcomes like systolic blood pressure, but it doesn't improve any inpatient important outcomes. And NICE basically came to the same conclusion, looking at a lot of different studies. The American Heart Association basically came up with the wishy-washy, you can consider it. Most private payers are not covering it, they consider it experimental. And staff is recommending that we put these on the guideline note 173. And then we'll include those T codes, although we can't bill for those just because for completeness.
Thank you.
And then we have the knee extra-articular implantable shock absorber. This is a device that is implanted around the knee.
That is handout page 53.
Thank you. To take, for people with osteoarthritis of the knee who either aren't candidates for or don't want a total knee replacement, this is being proposed as an alternative. The studies are somewhat limited. There's basically 3 studies out there that I could find, the Calypso, Atlas, and Phantom studies, a total of less than 200 patients. It does show that in this very small population, it doesn't appear to be worse than total knee replacement. The American Academy of Orthopedic Surgeons does not mention this as a treatment option. All private payers are considering it experimental. I consulted with Katie Schabel, and she agrees with the staff recommendation for guideline note 173.
Some of those studies compared to high tibial osteotomy, which is really an outmoded treatment that is very, very rarely used now. So again, they're trying to say that it's better than knee replacement by comparing it to high tibial osteotomy. There's a lot of methodological kind of limitations in the
So we
limited
didn't even
studies
compare it to
that
the
are low
actual
quality that it does,
thing.
yeah.
Okay. We have it.
It's experimental.
Agreed.
Then the next one is prescription digital therapeutics. These are basically apps on your phone or on your computer, and they are things that, these specific codes are for mental health, and they're the codes for both, for the app as well as for the services around what's needed, to educate the patient, monitor it, et cetera. So these are prescription devices, so they're not something that you can just download, you need to have a prescription for them. And then, and many of them have the ability to kind of track how well you're using them. They are, there have been, as of a couple years ago, 35 to 40 of these have FDA approval. And that's based on a med report that came out last year. They're looking at the landscape here. We have only done one, there was a digital therapeutic device for amblyopia, that was our only review, and that's kind of a totally different space. There are HCPCS, the A codes, the DME codes that we've also never reviewed. And we have the visual therapy one that we did review, we put on guideline note 173. So the Med Project did a review published last year and noted that the studies are limited, they're mostly funded by manufacturer, they don't really have long-term follow-up. But they did note that each of these devices that have FDA approval had to have an RCT, and they didn't look at those specific RCTs. And there was a lot of concern in general about clinical effectiveness, real world effectiveness, and sort of variability in how these are used. The only digital therapeutic that had coverage, Aetna is covering one specific one, it's a fertility app called Natural Cycles. Other private payers have guidelines about when they would cover them, but then they list all of the ones that they've looked at as being experimental. So this is a rapidly expanding field. There's a lot of uncertainty about the quality and quantity of the data, about the effectiveness and whether these would be effective in the real world. Private payers aren't covering them except for that one app that Aetna's covering. And of note, there is one evidence-based app which might fall in this space called CBTI that's published by the VA. However, that's free. It doesn't require a billing code. It's freely available. So we wouldn't be limiting access to that. So currently what the staff recommendation is to add these codes to Guideline Note 173. And we can review, we'll have to review each product that comes forward if there's desire to cover. What are you're making faces now?
Might be a lot of work. That's what.
Just to note that most of these are actually not FDA approved, they're FDA cleared under the 510K pathway. And in general, it means that the specific device has not been studied. It's based on predicate device.
Thank you.
What are they comparing them to?
Previous devices, even if they're taken off the market because they're found harmful.
And kind of a weird array of a logic stream of linking it to prior devices.
That's what I'm wondering, yeah,
It's,
what are they linking it?
there's a
You don't want
nice,
to go down that rabbit hole, it's really scary.
yeah, there's
Yeah.
a nice read of article in JAMA recently that
Yeah.
details this.
Okay.
It's icky. And then our last one is 365-day implantable glucose sensors. So there's been a lot of work recently. You obviously, I'm sure, all recall CGMs. We've discussed CGMs ad nauseum. Those monitors typically are inserted for 2 to 3 weeks and then they need to be replaced. The field is moving toward 3-month, 6-month, and 12-month monitors. So they're more like a Nexplanon, a capsule that goes under the skin, and then the monitor is kind of put over. And so the sensor that's in the skin or in the subcutaneous tissue sends messages to the receiving monitor to give you your blood sugar results. The studies show that these appear to be just as effective as the at finding when they compare them. They compare these longer term ones to just standard finger prick. They appear to be accurate within the mean absolute relative difference. But there hasn't really been studied about whether these things would prevent like ED visits or any other outcome like that. Private payers are covering them under their CGM. It doesn't matter to them whether it's a 3-day CGM, a 3-week one, or a 365-day one. These are only studied in small cohort studies. They do appear to be accurate with a good safety profile in those studies. But there is some in these, like the 365-day, after a certain period of time, more and more, like they stop working and more people have to be replaced. So only a subset of people actually made it to 365 days. So the staff recommendation is to add the new code to the same lines that have all the CGM codes. And then the other thing that we need to do, when I was looking at like the current CGM guideline, we added a couple of conditions that are metabolic disorders to the CGM guideline, but the CGM guideline's not on those lines. So that would just add those as a housekeeping item.
Do we know how much they cost comparatively?
So the statement that I put in here is that placement on lines does not preclude HST or CCOs from requiring a least costly alternative therapy or requiring step therapy.
And then does any part of the guideline note get in the way if it doesn't last 365 days, and if you get one at 300 or 250?
I don't think so. I don't think we say how often we.
Okay, because it sounds like most people don't actually make it that long.
So right now, people are changing them out every 3 weeks.
10 to 14 days.
Yeah, 10 to
Yeah.
14
Do they
days.
do that at home?
No.
Yeah.
Do that.
So, and those are, you get like this little thing that just, it's like a needle-ish thing that goes, and it's still connected, it's physically connected, and you can't disconnect it without taking it out. So one of the things that they're selling this as is it's like MRI friendly and, you know, like the thing stays in, you just take off the monitor, you don't have to take out the sensor. And then you just put the monitor back on, like stick it back on, it looks like take it, you know, like a little bandage.
April, this is Chris. Was there anything about like the rates of infection or how often they have to be removed if there's a complication? I mean, I certainly see folks with the CGM going through tons of sensors because they get sweaty and they can't keep it on. And so it doesn't always even last those 2 weeks. But I'm more concerned with something's in you for 365 days. Like, were there any, what did it look like for the safety?
So in the Precise2 study, they found, they only went to 90 days because that's what that device was being studied for, and 91% of the sensors functioned through then, and only one needed to be removed prior to the, and what they didn't, I could go back and look, but I'm not sure if they mentioned why, if it was an infection or not. And then there was another cohort study that the PROMISE study, and no device or insertion removal procedure related adverse effects were reported.
That's
I
great.
think this would be like Nexplanon is, we insert it for 3 years. There's probably there is a published infection rate, but it's very low.
That's great. I'm wondering if it's magnetic, the way it connects, but I can see that being really beneficial and actually more cost effective for some folks who are on these others, but I don't know what it costs, so it's hard to say.
These are smaller and shallower too, right?
Yeah.
Yeah.
Yeah, they're just like a little seed, like a little rice grain
Rather than,
that you, and you just put it in your arm and put the monitor over it and. Yeah,
This is good.
I think it's probably where people are moving in this
Yeah.
space. My only
Or-
concern is what other things could you start monitoring for with those implants, like HCG or like, I don't know.
I was like, are you getting microchipping thing? Is that what you're worried about?
Anyway, any concerns with, and I have not heard in my medical circles of this being on anybody's radar yet, but I'm assuming we'll probably start marketing it like
I
this.
think our only concern is cost. But
Yeah, I
That'll
mean,
come
you'll
down.
have to kind of determine if it's cost effective to replace a monitor every 10
Totally,
days
yeah.
versus doing this.
yeah, no, absolutely.
It may become a step therapy kind of thing.
Yeah.
I don't know that it may not be first option.
So April, will we be tracking this to see like who's getting the current approved models versus who's starting to go with these? If there is a huge, I mean, I think the actuaries, right, would be really concerned if there's a big price difference.
Well, if there's a price difference, one of the things in rule is that CCOs and HSD have to look at least costly alternative. So if this costs $20,000 and normal CGMs cost $500 over a year for all the med sensors, that would be the least costly alternative, and you'd have to argue why that's not working for a patient. But if these are $500 and CGMs are $500 for a year's worth of materials, then.
Yeah, so that's the year,
Yeah, especially with the whole FDA thing, these are actually only been studied for 90 days and then maybe, it's predicate testing, and they've done some for 365.
Didn't kill anybody in 90.
All right, so that's the end of the HICPIC code. Should we vote on those?
We shall.
I move to approve HICPIC codes.
Thank you,
We
Katie.
modified one of the, did we modify?
No.
We did not
No.
modify
Okay.
any HICPIC codes, I don't think. Okay. Second, anyone?
Second.
Second, Adrian, thank you, everybody. Vote, affirmative, aye. In room, online, or opposed? Thank you.
And just clarify, we took some options that Ariel laid out.
Yeah.
I assume it's as discussed.
Yes.
Yeah, HICPICs as discussed.
Okay, so we need to,
I actually, so we're needing to move to the benefit update project. Looking at our new discussion items, there is one item that we have to do. And I'm recommending that we look at the bone marrow transplant guideline. It's only because the rule is sunsetting. We looked at this last meeting and there was just some requests for some further wording. If you can indulge me, I think if we approve
So
that,
page
that will help with
602, please.
rulemaking.
Page 602.
And then we can address any of the other items after we do the BUP discussion, if it doesn't take until the end of our meeting time. So bone marrow transplant guideline, we talked about this in October. As I mentioned, there's a 10th guideline and they need to finalize it, to rule, they need to finalize it. What we discussed at our October meeting was that staff had not addressed allogenic transplants and how many antigen matches you need, which was in the old rule. They had a minimum of 5 out of 6 antigen match for bone marrow and peripheral stem cell transplants and 4 out of 6 match for cord blood transplant. So I've added that wording to the proposed new guideline. And then the rest of the guideline and the sort of the other changes that we need to do are the same as what you saw in October. So yeah, it was the antigen matching. And then donor leukocyte infusion. What did we put in? So there is one additional wording in there. Donor leukocytes are only medically necessary for patients who have prior medically necessary allogenic bone marrow or peripheral stem cell transplantation. I apologize, I didn't call that out in what you guys see in the wording. So those were the 2 pieces that staff were asked to address in the new guideline when we discussed this in October. Does that address the concerns? I think it was you, Max, who raised
Yeah,
them.
I think the other part was the peripheral stem cells are from the original donor. That doesn't matter in the old rule. We're just looking back and comparing for the donor leukocyte infusion.
Oh, from the original donor?
That's what you wrote was in the original rule. I didn't pull it up again. Like at the very beginning where it talks about the background.
Yeah, I'm looking at the rule. Donor leukocyte infusion, early failure or relapse post allogenic bone marrow transplant, peripheral stem cells from the original donor. So we can add that if you want.
Sure. I'm assuming whoever wrote the original rule. Yeah, that was our discussion last time.
Okay.
These were the rule. I don't know. I'm not an expert in the area, but I assume they still are required.
Donor leukocytes must be from the original donor.
Yeah, that's what it says. Peripheral stem cells are from the original donor. So.
Is that peripheral stem cells or donor leukocytes?
You wrote peripheral stem cells. I'm just not looking at the actual rule. I'm looking at what you wrote down. In
It's
the
donor leukocytes are peripheral. Oh. Why would a donor leukocyte infusion? It says peripheral stem cells are from the original donor. That's what the rule says. That doesn't make any sense.
Peripheral. And don't, yeah, that is.
I think we could just leave that silent and not change it, and we.
Yeah, I I just leave whatever the original is.
Cause, yeah,
You know, filter if those come along.
So don't add the yellow?
don't add the yellow.
Oh, just don't say anything.
Yeah,
Yeah.
cause I'm not sure what the original rule intent was, cause it doesn't make sense.
I guess I'm just
Let the
concerned that it's-
transplant people figure it out.
Yeah, something,
That's the
yeah,
reason.
they won't get it.
Exactly.
Well, I have had them have differences on the matching before, that's why I was asking about it, I have had that conversation before. Yeah, that's fine.
We good? Let it go?
So you should motion.
Do we need a motion to accept it as written? Which is what we want right there, okay?
So moved.
So moved, Max, second?
A second.
Brian seconds, all in favor, aye, or online say yes? Aye. And everybody can say nay if they wish. All right,
So we have quite a few things on the agenda. I would recommend that we all move to the benefit update project at this point. Like I said, we can go backwards and work on other things
Okay.
if we have time.
so we're gonna go here to page 224 of the HERC packet, and benefits update project will take us to Jason.
Yes, and so it's in the HERC packet. Liz?
And
Is
do
looking for-
we need to go to the HERC packet as well?
Yeah, you'll need to go to the HERC packet. It's at the end of the HERC packet on our meetings page.
I believe that's 224 in the HERC packet.
And Jessica, if you are able to post a link to that in the chat, that would probably be a favor to people.
Okay, one moment.
So today's HERC.
So not the handout?
Correct, not the handout, the HERC packet,
Which is the
the
materials?
materials, yeah.
Right, yeah, you have to tell us what word you use.
Okay, I think I'm in the
I'm sorry.
material, but it only goes.
Accurate or specific.
I'm sorry, this will all get simpler when we have one.
Yeah.
One,
So this should be a 260-page packet, and we're going to page 224.
correct. These are the slides that are gonna be on the screen, so.
Beautiful.
So this is an update on what, you're gonna get an update each meeting for a little while here. But you're gonna have more meat on the bones today, there's gonna be more detail, so we'll go through this. I'm going to go pretty quick, but hope you all slow me down on any parts that I need to be slowed down on. Because this is gonna be really important to understanding our work. We're not gonna make any decisions on this today. We will look at some actual language for a sample topic. And the purpose of that will be to get feedback on how we're presenting it, how we're organizing it. Does it make sense to you? Is it gonna be implementable for those of you in CCOs, et cetera. So, first of all, just this slide reviews from some background that we covered last month. I'm not gonna read all that, but the prioritized list is ending, and HERC will continue to have an important role in determining which services are medically necessary for Oregon Health Plan members. Our mechanisms to prevent undue influence by anyone will remain, much as they are today. This is just, a lot of things are staying the same, but the prioritized list will be ending, as we understand it. I should also say, in light of the election results and new administration, things can change when an administration changes, and everything here is based on what we know today. We will probably know more in a couple months. Let's go ahead. Again, CMS ended the waiver. The operational elements will remain. We'll have evidence review, just like we did this morning. Code pairing files, much like we did this morning, except without the unfunded region. Medical necessity guidance, our guideline notes, much the same as today. Our public process will continue. Our values of transparency, stewardship, equity, and evidence will guide decisions. Federal law allows limitations based on medical necessity and utilization management, so that will be our work. Some benefit and cost increases expected because some services are currently below the funding line, even though they're medically necessary. No reduction in population or benefits are planned because of this project. CMS had some concerns about the list that some mandatory services are not being covered. Members may not have access to full appeal rights. This is in our fee for service programs due to denials of services that are below the line. Oregon's funding line hasn't moved since 2012. Our insured rate is at 3% now. With the expansion population, there's less reason to limit coverage. And this project is an opportunity to expand coverage for some additional services. Bottom line, the waiver's ending. Again, this is largely a rehash of what I already said. I guess there are some new things on the right side of that. HERC and program rules will provide medical necessity policies. That's much of what we do today. Others will come from CCOs like they do today. Medically necessary state plan services will have to be covered. Some services will still not be covered, either because they're not in the state plan or because they're not medically necessary. And we do expect some increase in the scope of services, which will put some pressure on the budget. But we hope it's a small impact. I want to review what we've heard from some of our partners. And I'm actually going to look up some notes here that our project manager sent me. We've heard concerns about members not being able to access care. And, you know, a lot of that's outside of our scope, but there are shortages of providers, there are difficulties in you know, that's still going to be outside our scope, but that's what we're hearing as we present this. We are hearing difficulties with transitions between the prioritized list and the future state, resulting in prior authorization services. Sorry, transition? Oh, they don't want delays due to prior authorization services not being covered or causing delays. The process for obtaining some services is complicated, and we all are familiar with those difficulties. We've also heard questions about medical necessity, what that will mean and how they'll be applied to the newly covered services. We'll be covering that topic today in more detail. Hopefully we'll get some answers about that. We heard your recommendations about educational and outreach. I'm sorry, this is notes I'm reading from another email. We've heard that we should create accessible and easy to understand materials, partner with regional organizations, hold informational sessions to make things more accessible, provide technical assistance workshops. And then there were also some feedback about the fee-for-service appeals process, which will be beginning. And I don't know much about that, but we'll be addressing some of these things today.
This is actually a slide, if you want to advance the slide.
We're not ready. Oh yeah, thank you. So let's advance. I'm just looking at these other notes here because I got information after these slides and I want to make sure there's nothing. Yeah, I don't think there's anything else beyond what's on the slide here. You know, as I said, access is out of scope. For this project, it's an important issue, of course. We're going to talk about these coverage decisions here. There'll be an outreach strategy and we'll use the feedback about the member appeals process in that setting. From CCOs, concerns about the cost and financial impact, of course. How medical necessity is defined or determined, potential for industry influence. Concerns about dental coverage, pharmacy services, and prescription drug coverage, which are a little different than most of what we talk about in this room. How HERC will make decisions, changes to our work products, what those will look like, and impacts to CCO systems. Next slide. So for cost, we are assessing that. Been working on that this week. Rates will still need to be actuarially sound and set through the usual process. Any changes in our HERC decision-making will be vetted publicly, as they will be today, and with opportunities for meaningful input. The goal is to preserve HERC's published evidence-based decision process, providing consistency across the OHP benefit and ensuring good stewardship. For pharmacy and dental coverage, some medications that are currently denied based on the funding level will become covered. So if you have medications that are being denied and the denial says not funded on the prioritized list, that's gonna need to change. That said, clinical prior authorization criteria may be applied as they are with conditions in the funded region to assure appropriate use of medication as required by law. Dental coverage is unlikely to change. So all these changes, basically the unfunded dental services will become excluded for adults. For children, of course, there's a different set of rules.
Can we ask questions now or just wait?
Go ahead.
So with the pharmacy and dental coverage, I know dental coverage will unlikely change. But if currently, as it states, there are some medications that are denied based on funding level, that will have to be covered. And you're saying that though clinical prior authorization criteria may be applied to ensure. So I guess I'm trying to understand. It will, if it's based on funding level, automatically will be covered, right?
No.
It will be based on prior authorization, right?
Correct.
Okay.
So
And medical
something,
necessity.
allergic rhinitis is not covered because it's below the funding line. There are cheap over-the-counter medications for that, Claritin, et cetera. Unlikely those will have prior authorization. There are some other conditions, some skin conditions that have rather expensive medications. I would expect a lot of CCOs and our fee-for-service program will have some prior authorization criteria and step therapy for those kinds of things.
So prior authorization will be applied in certain cases.
Yes, everything will be like it is for the funded region today.
Okay.
But those criteria may need to be developed because now it's just a hard no.
Yeah, so all diagnoses will have to be covered, at least for an office visit, which means they're covered for medications.
And this will get clearer as we go forward, so let's keep going.
Okay, that's a good question.
And there will be more operational guidance for CCOs. So there are some things people are wanting to learn more about. I covered most of that. Let's talk about medical necessity and appropriateness. So we have gotten some guidance that our decisions at HERC, and this was asked for by this group and by the HERC last meeting. What is medical necessity? How does this apply? If we're making decisions about this, how does this change our decision making? And I think the answer is legally, we need to tie our decisions to these criteria. However, I've highlighted in teal there the kinds of things that we talk about as we have for the last 3 hours. Prevention, services must address prevention, diagnosis, and treatment of disease. They can help people achieve age-appropriate growth and development, the ability to attain, maintain, and regain independence, ability to perform activities of daily living. Medically necessary services must also be medical appropriate. That's the next slide. So we'll need to tie our decisions to these things. That said, I think we already do. If we find difficulties in that, let's talk about those. But this will become our legal framework. But if HERC makes a decision that something's medically necessary, that decision will have the effect of rule, force of law. But we just need to be aware that it ties to one of these concepts. Next slide.
And just to be clear, these are not new.
This is the existing rule.
These are the existing rules. They were reviewed and revamped last year and changed little.
And there's no plans.
And this is what we've been dealing with for at least the last 15 years. They're pretty much unchanged.
Right. And other things that weren't on that slide, and I see Max is going to have a question, but let me get through it. Services must be safe, effective, and appropriate for the patients based on the standards of good health practice by the relevant scientific or professional community based on the best available evidence. Now, a lot of people disagree about what the best available evidence said. You all will, and the commission will be the deciders. The most cost-effective of the alternative of service types and services. Some of that we get into in this group as we develop guideline notes. Other things, as was discussed previously, CCOs can just make those determinations on their own and add additional criteria. So this is just providing a framework for us to make the decisions we already made. Okay, let's open it up because I know there'll be questions.
The cost effective part, so are we going to have to focus on cost?
Well,
no different than we have been.
yeah, it's no different than we have it. So
Well, we just have the
the-
CGM one, if we're sticking to that, we'd have to figure out what the cost of it is. And I would
Well-
think we'd
Well,
only
no,
approve
so
one.
No.
you can still do least costly alternative, we can still say like, we don't cover Cologuard because it's 600 times the cost of an equally effective test. We can use things like.
We can, but are we held to it?
No, so HERC does not have to make any guidelines. If where HERC is silent, CCOs will be able to, as they do today, reference external resources.
Right, it
Yeah.
says most cost effective, so in my brain, when we're talking about that CGM earlier, if I have to figure out the most cost effective, I gotta look at all of them. I have to
But you
figure out
don't
what is the
have to.
most cost
You
effective.
can, if you want to deny something because it's not the most effective of the alternative levels or types of service that can be as safely and effectively provided, then you cite this rule.
But if I'm saying, so if HERC is saying this thing is medically appropriate, it has to be the most cost effective. The most cost effective is a single thing.
Yeah,
Or a
and this is
limited
a point
subset.
Darren made, it's a little bit different in an individual determination than at our 30,000 foot level that we're flying here.
It says
And
the
we want our
most.
coverage to facilitate coverages of services that meet this rule.
Right, that's why I'm just,
That
It
can
says the
safely and
most.
effectively
We-
be provided.
We should support decisions that align with this. We don't have to get into all those details. We can say in general, we could theoretically write a guideline saying, only cover the injectable CGM if the other one is contraindicated for the patient or some such thing. But there's no obligation that we have to do that full analysis.
And we can cover multiple treatments for the same thing that have different costs, and then it can be an individual decision.
how do you get past the most cost effective?
What do you mean get past?
I mean, that's intrinsic to the definition, right?
Yeah.
You have to pick the most cost effective thing in order for it to be medically appropriate, in order for it to be medically necessary. So I
Well,
can't
but
say I'm gonna
again,
cover a $10
remember this rule is, so services will be considered generally covered if they are in the benefit. For them to be, they can be denied when they are not anything like the most cost effective. So this is not saying you can only cover the most cost effective. This is saying you can deny when it's not.
So is cost one of
Like
the
there's things you
factors?
cover, and then for an individual patient, if like the lesser costing thing is contraindicated, then you go to the next thing.
Right.
Or like
Things
for
you cover,
drugs,
things
a
you
cheap
cover.
generic is preferred, but if a patient is intolerant to it, then the expensive brand name.
So like again, the CGM discussion, why
It'll
just
allow
say
us-
we
it
cover
will
this if you
allow-
have a
it'll-
contraindication?
We don't,
That's at a
We have to write in step.
we don't have to. No, we don't have to,
because
but
of
we
this.
can.
Okay, I'll ponder more, because to me,
Okay.
that's not what that says.
Okay, so are you simply saying that the cost effect is something that is just one of the factors?
It's just
Yes,
one
it
of
is.
the
factors.
In
One.
deciding that,
Yeah.
okay.
What we cannot do is currently the reason that allergic rhinitis, which is a medical condition, is not covered is because it's below the funding line. That can no longer be the case. But what can be the case is, before you get the allergy shot, let's try some Claritin. Or such and such a treatment is not safe and effective. Those kinds of things can be said, and those are medical necessity decisions. They are not ranking decisions where something is just below the line and we don't have the money for that. And this is in the mandatory benefits and the prescription drugs. In optional benefits, which include physical therapy, podiatry, chiropractic, acupuncture, dental, there's a little different calculus, and we don't have full information on that today. But for the mandatory benefits, we can create utilization management based on cost effectiveness. We cannot just simply deny something because it's not, is not cost effective. The cost per event avoided is too high. We can't just say, sorry, these CAR T medications are just too expensive. we're not gonna do it, we can't do that. Okay, so we can provide policy to support CCOs and fee-for-service in denying things that aren't the most cost-effective of the alternative types or levels of service. But it's not that we have to do that in every case, because how could we? There are 1 million people on OHP and they're all in different situations.
I think what's missing from the excerpts here is like at the end of the sentence, like B, C, and D, it's saying or and,
Yeah, this is excerpts, and I was highlighting the concept. The full rule is in our administrative rules.
Yeah.
And I can see some discomfort still. Please email us if you reflect on this and get more clarity, and I'll take that item away for further thought. Next slide. All right, so HERC's decision-making and standards, and this is my belief as of today, and this will be a thought exercise, our discussion today, won't change. HERC will value safety, wellness for the members, good stewardship. HERC policy will be reflected in code pairing files, coverage guidelines, and statements of intent. The OARs will continue to apply today. The changes we expect, in all the different program rules, all the references to the prioritized list will need to change in some fairly mechanical way. And then there are those core rules that tie the prioritized list to, excluded services, the state plan, the high level rules will have some more substantial changes to them. Go ahead. Next slide. So these rules will need consistent interpretation. So again, just as is the case, CCOs must cover medically necessary and appropriate services as defined by HERC as they apply to the member circumstances. CCOs can deny services that HERC says are not medically necessary, or they can cover them. Specifically, where HERC has made clear policy, CCOs can rely on it to support denials and uphold appeals. CCOs do have discretion to make exceptions if appropriate based on individual circumstances, as they do with the list today. And there can be unique patient circumstances, comorbidities, contraindications, late-breaking evidence.
Updates to the NCCN guideline.
Exactly. Where HERC is ambiguous or silent, we try not to be ambiguous, but sometimes when you apply something to a human being, we don't address all the nuance. CCOs can use that judgment and external resources and can email us and ask us to develop their policy. Okay. Again, the funding line goes away, the ranking goes away. So no longer will we have that thing about, line 300 is less than line 350. Denials based on the funding line. The comorbidity rule as it exists will not go away. It will go away, thank you there. We will continue to rely on this group and the HERC for consistent coverage, rely on the HERC for decisions to support denial for care that is not medically necessary, CCO discretion to use external resources, and make exceptions where appropriate. Now we're going to get into our meeting materials today. These are some screenshots of the meeting materials, most of this is. So this is a slide I presented last time with some changes to make it more accurate. You see the yellow pitchfork there. That will be our job. What's in the unfunded region, some of it will become not medically necessary. Some of it will become a newly covered service that is medically necessary. And some of it will be non-covered and not included in the state plan. And those decisions will also be influenced by funding and the agency ability to do things. So this is a line of the prioritized list, tobacco dependence line, which I picked because it is short. It is currently a funded line. We expect these services to remain covered since they are among the most cost-effective and beneficial in our benefit package. But you can see there in the blue and the red what's going to change. Just some terminology. expect them to look much like they do today. Any questions or thoughts or concerns about that? Let's look back at that one another moment.
So in using the terminology medically necessary, where appropriate, is that also equal medically appropriate?
Yeah, we'll need, that's a good point. We probably should say medically necessary and appropriate.
So what got taken out,
But-
sorry?
But
What got taken out is included on this line. So instead of saying those services are included on this line, we'll say they're medically necessary and appropriate.
And so like the coverage guideline is 2 code groups, we're making up numbers, these might not be real things in the end, but like 10001 is pregnancy, like line 1. So it'll be a code group. And then the tobacco dependence will be code group 10005. But we can't say lines anymore, so it'll.
The lines will become a code group, the guideline notes will become coverage guidelines.
And we still have diagnosis codes and treatment codes that need to pair. We are working internally to clarify, but I understand the point is that if a diagnosis and a treatment don't pair, then HERC has decided they're not medically necessary, so.
Well, right, and we will identify some coding groups and say these are not medically necessary. So that there's not ambiguity about did we review it or not. If we reviewed it and said no, we'll make that transparent.
And I think to Antoinette's point, we may or may not be saying medically necessary and appropriate because we're determining medical necessity, but then the coverage decision of what's the most least costly alternative for that particular individual, that might be like a medical appropriateness determination.
Medical appropriateness includes whether it's safe and effective. So I
Yeah.
think we need to address both of those in some fashion.
I have a concern about this, stating that this is medically necessary. If you have a patient who's tobacco dependent and you're their primary care physician and you don't provide this, or then you're shirking a medical necessary treatment.
This
that you
is
did
coverage
provide.
policy. This is not a guideline. So
Okay.
we set the table. The provider recommends the dishes that are appropriate for that patient to eat. Metaphorically, of course. So we're not saying
This
that,
is similar to like if you read an Aetna or a Cigna or a Blue Cross, they will say,
This is a
these medications, whatever, are medically necessary or are never medically necessary.
Gotcha, okay, I'm understanding, okay. It's about the treatment, not about the situation, all right, I got it.
yeah, so these are, this is saying CCOs, you need to cover this stuff.
Right.
If the doctor orders it.
Great,
under these
okay,
circumstances.
got it, thank you.
Does the research support the limits? They're not limits, but suggestions where it says you have to pay for at least 2. Did we look at the research
That-
and say
so that-
2 were helpful?
We did look at it in this
At
group.
least 4
and
counseling.
And there was also a federal initiative around this. I believe it's required by law, if I'm not mistaken.
Yeah, I believe this requirement is federal law.
But our job right here isn't to go through all the details
Yeah,
of
let's
everyone,
not-
you're gonna, this is just an example of how
This is
things
an
are
example.
Right, but I'm
We're not
thinking if we
supposed to
have limits in
scrutinize.
all these like guideline notes, we're saying they're all medically necessary. Did we actually get the data for those?
Right, that's
Like
why
notes
they're
on
there,
PT,
yeah.
notes on-
Yes,
So
Did
we
look at
don't-
before counseling?
We
Everything
usually
on
don't
the
put in
list.
anything with limits unless we've looked at
yeah, it doesn't, yeah,
There-
that's when, wouldn't have
There's
been
no other
created
way to put in
arbitrarily.
limits.
Everything on the list has been through this body and can be revisited. Okay, let's go to the next slide. Here's a sample, the staff recommendations like you've seen in this meeting. Again, it's nomenclature change. This is informational only. We'll look at it in more detail after the presentation. But you can see instead of create a new line, it'll be create a new code group. And in this case, there are 3 that represent conditions on multiple lines. And again, we'll go through that in more detail, but they'll look very much, the same, similar things to what you're seeing today. Let's keep going, then we'll take questions after we do a couple of slides here. So there's a sample coverage guideline recommendation for allergy testing. Go ahead. And allergy treatment. what we've added there is the date of last review. That was a request by some of our CCO partners, I believe, just to help us know when something was last looked at. And there's food allergy testing and treatment, which is different than the other kinds of skin and nasal allergy.
This will make more sense, I think, when we
Yeah, we'll dig
into
into
the
this.
detail.
And then there's a table listing the codes, again, similar to what you see today, but the code groups instead of the lines.
So, and this is a very weedy question, but maybe if the code groups were replacing the lines, it's just the 10001. Just a bad example, because that would to me fall into like pregnancy, or now they're going to be like different code groups.
I changed it in different, I think it's what you mean, it's like it's gonna be like 10XXX.
Okay, so the 1001, there'll not be multiple things that are categorized. It's
No, each will
1001.
have its own unique number.
Okay.
The difference from today is, today line 1 is prioritized above line 400.
Right.
Tomorrow, these will be meaningless numbers to identify a policy. They won't indicate any ranking.
So it would really be helpful if it was the same.
Well, a lot of lines will be ported directly over to code groups, but other ones will be reorganized. And so there will be,
Yeah, the default is covered lines will just convert over to a code group with basically the same number. But as I'm going through this, I'm reorganizing some.
It was old dogs math is a long time ago.
Yeah,
Everything memorized.
That's whole mental shift.
Yeah.
Yeah.
Well, I mean,
And
it's
then
fine, it just means I just like,
uncovered ones get a code
I know
group
that line
too.
so-and-so is something and it goes to
And there
the
was
same.
no distinction in the code group that it used to be an uncovered line or anything like that.
No.
Well,
20000.
again, they'll all be covered lines. There will be medically necessary lines and not medically necessary lines.
But
There's no line
distinction
is
in the
not
code group
medically
that
necessary. So all diagnoses have to be covered for at least an office visit. So there's gonna be a code group that is just office visits, that's gonna be ginormous.
Well, right, because you don't know what the diagnosis is until
Right.
you're seen in the office.
Right, and we currently don't restrict. So if you have
Right.
fibromyalgia, you can see your primary care doctor every week and we're paying for it. But if fibromyalgia is not paired with it's not in the physical
Yeah.
therapy code group or it's not
Right.
in a surgery code group, you can't get those services
Gotcha.
for it. We have determined it's not medically necessary for fibromyalgia.
Okay, that makes sense.
Okay? Oh, additional diagnoses will be recommended. So this is a table of diagnoses. There'll be, there's more than you can see on the slide. Similar tables will be produced for the procedures, prescription medications, criteria for medications would be updated, where we mention medications in our guideline to remove less references to the funding line. And the Pharmacy and Therapeutics Committee will be doing a similar process anywhere their criteria reference the funding line. And the CCO, Pharmacy and Therapeutics Committee, will need to do the same. Here is an example. Sorry, go
Ask a
ahead.
question. So I'm just curious, for the ICD-10 codes, I see where it makes sense. What about the diagnostic ancillary? We have some other groupings and categories. Is that what you're having to try
Those are
to
gonna
put
continue
into?
and they might get some random number, like the diagnostic procedures file might end up being file 4000, but we would still call it diagnostic.
I think those will be, we won't maintain those. Those will be Medicaid maintained as they are today. I think nothing's gonna change because that would require MOS changes and cost money and we'd be 3 years
Yeah,
away.
so we call something a diagnostic procedures file and Medicaid and MMIS call it, like, I get confused because they'll be like, is
They
this in
call it-
group
they call it-
1019?
Code group.
Yeah.
We call it a code group already.
Right.
So we,
Oh boy.
doing that.
We better not, we hope we don't overlap their code groups.
We will make sure we don't.
Yeah, but yeah, so that really won't change. And
I think
it's-
we'll start with that
Group
10,000.
118.
They're
It's
four
four
digits.
They're 4
digits. Total
digits.
group 118 is diagnostic.
But we'll still call it diagnostic so that we all,
Know what we're talking about here.
because I'll get too confused and then I won't be able to tell you what's going on.
Okay, and this is for IT people. Again, we're just changing the names of things. The file format will be exactly what it is today. Next slide. Services that are not medically necessary versus not in benefit. So currently, our prioritized list muddles things that aren't in the benefit and aren't medically necessary. For example,
So we should probably define not in the benefit, so this,
I'm about to do that. So not in the benefit, we'll start with the bottom half of the slide, infertility services, GLP-1 for weight loss, dental crowns and root canals, even though they're in the funded region of the prioritized list, and eyeglasses. Not medically necessary, platelet-rich plasma for knee pain, epidural steroid injections for low back pain, excision for lingual frenum for tongue tie. Oh, hopefully not lingual frenum for tongue tie. Hopefully tongue frenum for tongue tie. Spinal fusion for a person without nerve impairment. Those things now are below, either they don't pair or they're below the funding line. In the future, they will just be not medically necessary. So the denial reason currently, in some cases, will need to change, but the outcome will be the same. So that'll be an issue for the systems folks and for terminology for your policies. And so they'll need to have different messages. And for example, that excluded services guideline that we just reviewed this morning, now we can say those services are excluded and the rules are a little bit complicated and ambiguous. In the future, those will need to be changed to not medically necessary because there will need to be appeal rights. They will be technically in the scope of the benefit package, although again, they can be denied because HERC says they're not medically necessary.
Okay, that just threw me off. I can get the not in benefit and I can get the medically necessary, but we're going to start putting things that are not in the benefit into the not medically necessary?
No, it's okay. For so for example, Cologuard is on guideline 172. We just moved it to, assuming HERC approves, to the excluded guideline. That is technically excluded from the benefit, although there's a little bit of ambiguity about that in rule. CCOs can always make exceptions if they want to cover it for some reason. That won't be allowed anymore because that's a diagnostic service, so that'll be inside the scope of the state plan. So we can't say it's excluded in quite the same way. What we can say is it's not medically necessary, and that's a case where the reason it's not medically necessary is not because it's not effective, but because it's not the least costly alternative in general. And so we will say it's not medically necessary. A member can appeal that and say, hey, this is this service is, the X, Y, and Z reasons why this is the best service for me. The provider can say that to the plan. The plan should consider that and make its decision about whether to use the general HERC policy or to make an exception.
It seems like it does. It just feels contrary to our concepts of transparency because we all know we have a finite amount of a budget. And I look at eyeglasses and I have a hard time telling someone that they're not medically necessary.
Yeah.
But it's more realistic to say they're outside of our benefit scope.
Exactly. And so that's why if somebody were to submit a claim, let's say for an infertility service or a GLP-1 for weight loss, that denial notice should say outside the benefit package. We just don't.
Okay, so it's not going away. It's not all going to just get lumped into.
That's
That's
the not in benefit outside the scope of the state plan.
Okay.
These other things that are physician services, hospital services, x-rays, labs, if we're denying those, it'll need to be because it's not medically necessary. Then you can appeal that, and that's at least a slightly longer conversation than for those things that are just off the table.
So the not medical necessary has a second half to that statement, or least something that addresses, or the least cost-effective option.
Yeah, I'm sorry. It should be not medically necessary and appropriate. The difficulty is federal law doesn't have medically appropriate. We do in Oregon because of complicated reasons that I'm not going to get into today. But anywhere you see in this slide said medically necessary, think medically necessary and appropriate, which includes safety, effectiveness, least costly alternative, et cetera.
And also the one thing on there about like lip tie for tongue tie. So things that are knee surgery for shoulder injury, like those are not medically necessary because they're,
Why would you do that?
why would you do that?
So the top half of that screen it's a slightly softer denial. There are room for exceptions, individual considerations. Bottom part of that, those are just outside the benefit package in the same way a new car would be. It's just not something we cover under this plan.
So will the full definition of that medical necessary be close to where these things are posted? Even if it's in a
It's
footnote?
readily available now. We use them all
Okay.
the time. This is nothing new. These definitions have been around
Yeah,
forever. So it's nothing new to those of us that use the list every day in our work.
thanks.
I realize this is a lot to adjust, folks. So we'll revisit this in
Just
context.
one more, maybe quick question, is this now more like what other states do with?
Exactly. More like other states, more like commercial plans, more like Medicare.
But our work is still gonna be reflected in there really deeply. You know, some states will pay for, I don't know, what was one of the things we talked about this morning? CAR-T, or actually, it's not bad, but, you know, the platelet-rich plasma, some states may just decide that they're just gonna, they'll just pay for it. We can say, we only pay for it for elbow arthritis, because there's good evidence, or
Or
we
we
can
don't
say,
pay for it at all.
we don't pay for it at all.
It's not medically necessary.
And we'll do that in public, which is really an outlier.
Meaning other states don't have public processes that are transparent as they
Exactly.
develop their coverage
Exactly.
criteria.
Exactly.
So there is one prioritized list in the world. At the end of this, there will be 0 because Darren's taking it out. But there will still be one state with this level of public transparency and process around these sorts of medical necessity decisions. There are a few other states who have things, but I think, Val, we agree that this is we're the most in the weeds on this stuff.
100%. Yeah. I mean, there are states where they have one medical director that makes all the determinations.
Right.
And in Oklahoma, the statute says that whatever that person says is what's medically necessary. They don't define it out.
Yeah, so we have,
it ranges.
thank you for your service, everyone, to ensure we're making good decisions and it's not all
That it's not just one person.
hands. Yeah.
Or the rep that brought lunch that days.
Yeah. So let's go on to the next slide.
Passionate appeal, right, yeah.
Again, medical necessity and appropriate rules are not changing. CCOs will have to cover services HERC decides medically necessary, just like they have to cover services in the funded region. CCOs can deny services HERC has decided are not medically necessary. CCOs can rely on external resources for medical necessity where HERC has not made policy. So if we pair something in a code group, we don't have any coverage guideline. The example was given of an ankle MRI or some rare surgery, and you have a resource that says this is just not safe, this is not effective, then you can use that to support a denial and everything will go very much as it would today if that's a service in the funded list and it pairs and there's no guideline. And CCOs can and hopefully do make exceptions because people are diverse and have diverse needs and we can't cover every nuance in this setting. Okay. Again, HERC will continue to be independent, governor appointed. This is all pending approval by our legislature and governor. We'll continue to use evidence-based transparent processes, balancing participation between members, CCOs, providers, and others. HERC will continue to consider equity in decision-making as we are able. HERC deliverables will evolve with only necessary format language changes. We're trying to make this as smooth a transition as possible. Go ahead. How decisions are being made. So now let's We are hiring additional medical director. Again, please send them our way. Ariel has been doing research. You can see there the groups she's already met with. We're OBGYNs next week. There's more coming in the next couple of months. We'll prepare proposals. We'll bring them to the CCO work group and HERC at 2025 meetings. I actually think for our January meeting, we will publish more meeting materials than we are able to address in the meeting, just for the fact of getting them out there so people can be prepared when we do have a discussion and can give us informal feedback so that we can
We'll probably
modify them.
publish 10 specialties and probably only get through 4 or 5.
So it's gonna be a lot of information. We may need an extra meeting next year. The goal is to finish this review by the end of 2025, 1 year from this meeting. And so it's gonna be a lot of work. We will be coordinating with our actuaries and our budget so they can plan the necessary funding. So there's gonna be a lot of moving parts to this.
You say the review to make sure that all of the transitions look correct.
So you'll see, like, we'll do the allergy one as an example. I think that's what the review, like, everything's gonna be converted. It's like
We have to
here
review
with
it.
ICD 9, ICD 10.
Yeah.
You have to review it. Some of them will be straightforward.
Right.
We will try to focus the discussion
Yeah,
on
I
the
was gonna
topics
say, that's gonna be
where
important.
there's a safety concern, where there's a cost issue. You know, if it's non-controversial, not potential waste, fraud, or abuse, you know, it'll just become covered.
Okay.
But for those items that require discussion, you want to do a really good job.
Right, okay.
Yeah, so a lot of it's just easy work.
A lot of it's just administrative in a way,
Yeah,
but
we'll
then
page
some of it's
through
not
it.
gonna be, we're just gonna have to stay focused and have a clear set of criteria for when we really need to dig in when there are those concerns of either cost, waste, fraud, abuse,
And we
safety.
will probably have experts who don't agree with the staff recommendation who may come to meetings to review.
Just like they would have when we were setting the original coverage, that was never,
Exactly.
or prior, spot on prioritized list.
Exactly.
Right, so it's like visiting.
Yeah.
It's-
Like the proton beam
It sounds
discussion,
horrible.
we're still gonna need to have that.
Okay.
The only thing I would say about others we should meet with, where's primary care in here?
That's Ariel.
So the
I
things
think
that
we should
are,
meet with some outside folks.
okay, because the things that aren't on here are, there are multiple things, there are multiple conditions below the line that only require office visits, like viral infections, diaper rash, all those kinds of things. I'm happy to meet with more primary care, but a lot of them I thought were very straightforward and just didn't. I will look for at least one other person, probably Don Lautner, to review them. So there's a second set of eyes.
But we can also, and we'll also publish the meeting materials and people can offer comment. Yeah, if you're like in primary care, a lot of it's just office visit codes, supplies, medications. Those are likely all gonna just land on one line with office visits, or one code group, sorry.
Who's gonna be the
Okay.
But if there are as we get into the depth of that, what we're doing is we're comparing those lines and saying, oh, there's a couple other codes here, we need to review those separately, we'll pull them out, we'll do that. So like one of them will be warts, that's primary care, but there's a procedure for that, and we'll need to develop criteria for that. Okay.
This is Chris. I have just a really practical question. Since you're still looking for that medical director, I'm just wondering if there's an option or if it would be helpful to think about like bringing on a coder for some of that administrative stuff, or if you already have that.
We have some coding expertise in-house, and
Thanks.
yes.
Cool.
Okay. Looks like Brian stepped out for a moment, but we will continue. So we plan to release a review tracker. Currently, much of this lives in Ariel's head and personal notes. We will make that look nice and put it on our website. and keep it updated because a lot of people will be watching this. Goal, all decisions about current below the line services made by December 1. The meeting materials will include detailed code pairings and guideline text, decisions in the minutes as we are accustomed to, except we'll just have one packet, which will, meeting materials. We will start releasing previews of the draft policy deliverables, which are, what's now the prioritized list will become, I'm not sure we have a name for the new package of things, but we'll have a draft, like a beta version, somebody said, late next year. And then we'll be doing dual maintenance of the list and new deliverables throughout 2026. And the final version will be published December 1, 2026, so that we can include any decisions made at that November meeting about new CPT codes and so forth. So that's a lot of work. I think we mentioned we may combine lines that have the exact same procedures on them into a single code group just for simplicity. We'll focus our guideline development on procedures with potential for waste or overuse, safety concerns, that sort of thing. As we review some things that are non-controversial and don't have significant cost, we may just put those on a consent agenda early in the year and throw them out there.
That would be great, and then since we know the kind of added importance and optics on this, we can make sure we review those before meeting, but
You've
I
already
think,
seen some the last couple of meetings.
yeah.
Yeah, she's just saying review before the meeting, so we can get to the
Yeah.
meeting and
So
just
that
say,
I guess another thing
move through the ones we can move through, I think that's what's gonna be really important, is that we don't get stuck on every detail of every one, if they're just.
right, because most of these things have already been reviewed, we don't need to review them again.
Especially the ones that have been reviewed recently and aren't controversial, like we should just buzz through those.
Right, exactly.
And as they get farther away, they probably deserve a little bit more scrutiny, but still, yeah,
There'll
the
be
easy
things
ones
that-
we have to keep easy, I think that's what I'm
There'll
trying
be
to
some
say.
like the dental lines that it's optional, and so we have to direct it to not add benefit. So anything that's below below the line in dentistry, it's just kind of, that'll be almost consent.
That will be outside the benefit package, it will be in a separate place so that that is clear and it can drive the systems to get the correct denial code. Okay. The next one. All right, pharmacy. This is our pharmacy. I'm not going to go into detail about it, but again, if you have colleagues interested in prescription medications, you might want to look at our plan for the Pharmacy and Therapeutics Committee. Again, the CCO's Pharmacy and Therapeutics Committee will need to undergo a similar process. This is the timeline for public engagement. Key part of that is that our public meetings right there in the middle of the slide will go through the end of 2025 on this project. That is our goal and North Star. I hope we can do it. There will be some public meetings in other settings for CCOs, a work group for CCOs, updates at the Quality and Health Outcomes Committee, affectionately known as QHOC, HERC meetings, and those will be posted on our website. There will be also, I believe, some fact sheets and FAQs and that sort of thing available there. If you know people who are interested or want to check on the latest information, please go there. So, and again, this slide is from our CCO session last week, but you all know where to contact us at herc.info, or these email addresses here are for the waiver team, and those go into tracking to report to the federal government. Let's go ahead and go on to the next issue, that allergy summary.
What about lunch?
It should be arriving anytime.
No, lunch is here.
Oh, it's here?
Lunch has been here.
Let's take 5 minutes to distribute that and get it up on the screen and.
Okay,
Plow
break
through.
break for lunch, 5 minutes, go.
Yeah, all.
Yeah.
trying to mix up a little bit of meeting time. Which is good.
Okay, so I don't have to roll out.
Thank you.
She just checked it out for that.
Thank you, Val.
So my husband dropped to part-time a while ago in the first place.
Okay, there's that.
So, because we had,
There's that.
like, about a year, at that, a year ago, a little more than.
Okay, we're gonna get started, folks.
Alright, so I am bringing you all,
Lunch break over. Lunch break over.
alright, my foodie is over here, so let me crunch it. I am bringing you the benefit updates allergy, and this is, we're not making any decisions at this meeting, this is more to socialize kind of what I'm doing, get feedback from you all. So you'll see if you had a chance to look through this summary, there's not a lot of evidence review, because we have policy now, we're just really changing our policy. I did include an expert guideline because of, and I sometimes will look for other insurance policies, more for wording choices. The reason I'm bringing allergy to you is that, this was actually the first group I met with, they actually self-organized and came to me with a proposal, so it was actually a good, easy group to work with. And I thought what they brought was very reasonable. And then it got some good examples of things that we should probably just double check with you all that this is where you wanna go. So this is kind of what you'll see. you might see a guideline if there is a piece of something that is controversial, or especially if, like, for example, I met with the breast surgeons and they're very much in disagreement with me about using acellular dermal matrix. That will actually be its own evidence summary, like you're used to. That, you know, goes into detail with studies and things like that. If it's something where there's not, we've already looked at the evidence. For example, some of the behavioral health things we've reviewed in the last couple of years, that psychotherapy doesn't help. So I'm just gonna kind of reference, you know, we talked about this in 2022 and this wasn't paired, so that will give you background into why that is. So we're not revisiting decisions. And then you heard earlier that most of the current covered lines are just, for ease, gonna be converted and just en bloc to a code grouping. But like, some of them won't. So I've met with, so the allergists, you'll see this, ophthalmology also. We had a lot of things that, we smooshed lines together where there were like diagnoses on it and treatments for some of those, but not all of the diagnoses. And so there could be weird pairings where something was totally inappropriate, but it was on that line to pair with something else. Those are gonna be teased apart. So hopefully it's actually an improvement.
Yeah.
It's just a lot for you to like, it's a lot of balls in the air to juggle. So what you'll see if there's like a small evidence review, like the experts said, hey, everybody does this at standard of care, and I find like, oh yeah, there was like a Cochrane review in 2010 that said yes, and all the guidelines say yes. I'll just kind of summarize that really quickly to give you background. And then you'll see who the experts are under expert input. I will put the experts that are consulted. Those are the experts that will have met with me and that I will then send out my recommendations to give feedback. If there are other experts, like, so the two allergists that I mostly work with, Dr. Yoshi and Dr. Anstey, if an allergist from the community gives us feedback, I will probably note that separately. I'll just say, you know, Dr. Jones wrote that we need to do X, Y, and Z or something like that. And like the gynecologists actually self-organized and they're having one spokesperson rather than having lots of voices in the room. So I don't know how I'm gonna do with that because I'm probably gonna need to consult with the subspecialty people about their specific little things, but as of now, this is what I'm gonna show you. There's gonna be a very short staff summary. And in some of my versions, there's not even a staff summary, it's just recommendations. So the recommendations are going to look different than what you're used to, but they are very similar. It's just a different format, different words, but a lot of it is just really the same decisions you've always been making. So for the allergists, they came to me and they said, there are conditions that need to be allergy tested. And most of those are contact dermatitis. You need to know what you're allergic to and you avoid it. You don't need any testing. There are things that need allergy testing and then treatment, and you need a guideline for restricting that. And then there are food allergies, which is a totally different animal, and please separate those out. So what I have done, and in order to make this operational, I actually had to pull from covered lines. We have shoved a ton of allergy stuff into covered lines because most of the allergy lines aren't covered, and there's a lot of stuff that makes no sense. Like, we have allergy testing on lines to go with like one diagnosis. So I'm pulling those diagnoses off and into these code groups. And so in the future state, in 2027, there will be 3 code groups. Well, this is the proposal. And actually there's always a 4th code group, the office visit only. So if something doesn't need allergy testing or treatment, it just needs an office visit for someone to say, that's all, you know, you don't need anything, then it will be in the office visit only line. And you'll see that a lot. It'll appear a lot over and over. I don't think there's any in this particular, but a lot of the other ones, will be an office visit only. And then this one will have allergy testing, so a diagnosis may appear in 3 of these groups. The treatment codes are only gonna appear in 1 group. So the code groupings are really gonna be based more on treatments. So what diagnoses need allergy testing, what diagnoses need allergy?
659.
Thank you. If it's not pairing, it's not medically necessary, that's our definition current. We think that will be operationalized. So in all of the treatment code groups, those will all, so we're probably gonna make office visits diagnostic. So like the 99213, 99214, so that, you know, if somebody has contact dermatitis and all they really want is someone to tell them that's what it is and they don't really care about being allergy tested, that would be a reimbursed visit, you know, leave procedure. So then you'll see, if you could page down just a little bit. So you'll see, if you could go down all the way to the table. So the way I have it organized right now is I tell you the code groups. The code group numbers are meaningless at this point. And then you'll see these tables, and and in this example, I'm pulling from covered and uncovered lines, and I'm pulling all these diagnoses. So asthma will be in this group, but it will also obviously be, if there was another treatment for asthma, procedure, it would be in that group as well. But it'll be in, because we've always covered allergy testing and treatment for people who have like allergic rhinitis and asthma. So a lot of it's really just showing what we've always been doing, but making it more obvious. So rather than being a comorbid asthma condition, asthma will be paired.
So I want to ask a question, if you could scroll up a little bit. So allergic dermatitis of the eyelid is on the testing line, or code group, but not the treatment code group. Do you need at the CCOs or plans, in the last list of the larger group, a code group that says no allergy treatment? In order to be clear that HERC has reviewed it and said no versus just being silent. Because that would be a lot more work for Eric.
So it would not pair.
Right.
As long as the pairing holds up.
As long as, it'd be like a non-pairing in the funded region.
As long as it doesn't pair, I think we understand.
You're good.
intent.
Wouldn't the excluded group also provide
Not-
that information?
It would also not
No,
pair.
so this, like allergic dermatitis of the eyelid, it's not excluded. We would pay for you to have a dermatology visit to be diagnosed or an ophthalmology visit to be diagnosed. And actually that's a good example because this is actually gonna show up in ophthalmology because ophthalmology has their own visit codes. They're special. So allergic dermatitis of the eyelid will show up in the ophthalmology visit group. It'll be covered for office visits and it will also be covered for allergy testing. It'll show up in 3 code groups. But it will not show up in the allergy treatment code group. So if you want to do allergy shots for your allergic dermatitis of the eyelid, at this point, my understanding is you would deny it as not paired.
Right. Good. Where?
But you deny it as not medically necessary because HERC said so, not as not consistent with the prioritized list or whatever.
Right.
Yeah, so it's one more step. Instead of saying it's not paired, not pairing indicates not medically necessary. And then if you could go down to the procedure, the table that's a few more. So these are all the ICD-10 codes. In some cases, I just put families or ranges because I just can't type that much. And then otherwise, I will pull out specific ones because they're even in the same code family, they're different. Then there'll be CPT codes. And then these are more, so you can see where all of the current lines that have these codes now, you can see they're just a mishmash. So it's actually streamlining it a bit. And you're not gonna be able to do skin testing on line 9 or line 310 for something that doesn't really actually need it. We're unpicking apart some of this stuff.
Okay.
So in the new world, so code group 9, can you stop for a sec? Code group 9, code group 123, code group 221 will no longer have those codes. So those lines, when we convert them over to the code group, will look a little different than today. Does that make sense? So standard, we're just gonna take line 9 and move it over, but then we're gonna have to on the back end also say, oh, like we're taking all the allergy testing and treatment stuff out of that line because they're already in a specified code group. Makes sense?
For the asthma example, because that pairs with, you're gonna have it align with testing, it's gonna be in the testing code group now. I mean, all asthma is not allergic asthma. So is there like a guideline note or something that guides that?
I don't, but that would be exactly the kind of thing I would want brought up. If that is, you know, so
I don't think
this-
that's really gonna happen, but like
Right,
technically it
but
could, right?
there is a amazing volume here,
Yeah.
and I'm gonna miss stuff. So if you say, oh, wait a minute, like you can't put all of the asthma codes there, you should just put the,
There are allergic asthma codes, right?
there probably are,
I think
and
there are.
when we can make a note about that, and I can look for the allergic asthma codes.
Okay, so
although
I
we-
ask you,
Right,
is it test bed month? The
This
answer
is
is
totally
I
a yeah, no.
ask you. I
Right.
understood that and I asked, okay, cool.
yeah,
Okay.
and that's exactly what we will, those are the types of things that's why we're bringing it to all of you guys for your eyes and your brains.
Yeah.
Because
Yeah,
you're
but
this many more people.
the asthma line has traits. And so there will need to be a separate asthma line group that has traits. That unrelated to allergies, and some of those same diagnoses might also be in the group that requires allergy testing.
And we're not gonna be doing a lot with the covered lines before the end of 2025 because there's just no bandwidth. So
Right, I
there-
mean, like that and allergy testing, can we just say, let's look at the billing later, because I don't think anybody's gonna try and trait every asthma. Right, like, it's probably not worth spending our time making a
Right.
guideline note.
and we can make
we can't.
trade
Right.
exempt, which means, or traits exempt, which is where we put a lot of.
So line 9 is the allergy line. That will become line 10,009 or
Right.
some other number. And nothing else will change.
But like when we discuss, so this is a test case, but let's say we were
Yeah, yeah.
discussing this for a decision today, you could bring up, I think you should look more at the asthma stuff. I would say, okay, great, highlight it, pull it out and say, you know, we'll approve all of this and then when I come back to the next meeting, we'll have sort of previous discussion and it'll say, you needed me to look more deeply at asthma, here's how it's changed.
Okay.
And yeah, that's exactly the kind of feedback, or we may get an allergist coming, well, probably not, but like, we're gonna have a breast surgeon coming and arguing, you need to add this diagnosis to this type of breast surgery. Or like a lot of the breast conditions I put on office visit only, there's nothing like fibrocystic breast disease. You could have an office visit to be diagnosed with that and told about it and whatever. But if a surgeon came in and said, actually, no, we need to do a double mastectomy for that, and this is all the reasons why, and here's the evidence, we would have to debate that. I mean, that's a silly example, but. Okay, and then the other piece is the guidelines. And most of these are current guidelines with the words changed. So instead of guideline note 10, it'll say coverage guideline, whatever, code group, instead of line, the data last review, which I realize is not September 20th. That was probably when I sent it to the allergists, but you know, it'll be the date that we review it and it's approved at HERC. And that'll be really helpful, I think, because a lot of the CCOs are like, when was this last review? We have to go through minutes. So, yeah. And instead of saying it's on this line or not on this line or on an uncovered line, instead of having instead of referring to an uncovered line, it'll just say it's not medically necessary if it's not. Like, so this one is allergy testing is not medically necessary for any ICD-10 code not occurring in this code group. Or we could not do that, we could take that out and that could be assumed, I mean, it's all, this is fluid and we want your input.
Well, let's discuss that item. Do you want that last sponsor? That would be something positive you could cite
I don't
as
think
opposed to something, the absence of something.
I don't think it's implied by non-pairing, right? So it probably won't take any more effort to put that in those guideline notes. It makes it clearer.
Agreed. So the difficulty occurs when, for whatever reason, we missed an indication for something. And that will look exactly the same as if we reviewed something and said no.
Right, that's, yeah.
We catch those all the time,
And we catch those all the time,
and we send them to you all the time.
so you're thinking that's okay. Okay. That's exactly the kind of feedback we need. And
I
what,
think this is Mary, and sorry if this was already stated, I have a little bit of a hard time hearing a couple of people in the room. I think there was a comment about, do we need to keep the bottom sentence, testing and treatment is not necessary for any code on appearing in the script, or is that redundant? Was that one of the questions?
correct.
We were just discussing that.
I think I need that, and the reason is it just seems like when cases go to hearing, that would make sense to an administrative law judge, that it would be helpful. And obviously, we're all gonna interpret medical necessity for every review based on the individual patient's condition, but I just think it might be helpful, because that's something they really do go through those with a fine tooth comb, so I think it'd be helpful to leave it.
Thank you.
Great feedback, thank you. And then if you go down to like food allergy treatment, there's the following limits apply, and this is where we put in limits. You haven't seen this one yet, but the lovely allergist came in and said, you need to put this test numbers in your guideline because you're overpaying. Yay. So this says, and you haven't approved this, so this is just a mock-up yet, but cutaneous allergy testing is allowed 60 times per year, so that's 60 different, apparently they're doing 120 in some places.
119. I don't know why, but it's 119.
Each one is a instance of testing. That's a weird.
We need units, right? We don't need times per year, am I misunderstanding?
Yes, you're right.
The units?
So
Okay,
60 unit, it would you say 60 units?
60 units, okay, so we have did a research on this, or something, you guys have more update, ours weren't that high, but I think this would be reasonable to add, because we do see requests like 120, 200, and some pretty nutty things, it's like someone eats a piece of melon and they have a rash, and so this is good, and then the other thing is it might be helpful to add those on allergy, on immunotherapy, 2 allergy shots. Because the literature search we did said basically 50 per course of treatment, and we get requests for way higher than that, and maybe the science has changed on that, but that might be another thing to look at.
Okay.
So limits on how many substances you can do immunotherapy for?
How many times?
Or how many times?
How many allergy shots, like I'm allergic to grass, and my allergist wants to give me 400 injections, but the medical literature supports like a course of 50 and then kind of gauge the response before proceeding.
Okay.
Yeah, 3 times a week for 3 years. Or until the patient stops showing up.
Right.
This is just an example, but we're not like digging in.
Yeah, we're not gonna do.
Okay, ask some
We
other
actually
questions.
do have an issue, if you wanted to go there, that we could talk about and
Well,
approve. Like the.
Let's get through everything before we get into clinical
I
issues,
think we
but
should be
Yes.
either learning about this mode or dealing with an issue mode, but not like flipping back and forth, because that's gonna be hard to, I think,
Yes.
focus
Yeah.
appropriately.
Continued demonstration.
but the structure.
Yeah.
That's
So,
what we're focusing on now.
Yeah, so essentially what I really wanted to I've gotten a lot of really good feedback, and also wanted to socialize you all on how this is gonna look different. So you'll have code groups. In this example, I put in the 10001. Future examples will just have probably either 10XXX, or we might just say code group and then like a little TBB or something, because we don't know how we're gonna number these yet. And then the guidelines you'll see, and most of the guidelines are literally word for word for what we have now. this was an example where the allergist proposed some differences, so we would discuss those changes, and we would have to do them to the prioritized list as well as to the BUP. If in the next year, like, if we talk about allergy testing limits, and we approve them in January, we'll have to have a guideline for the prioritized list that does the prioritized listy stuff and a BUP. So it'll be the same words other than on this line or medically necessary or whatever. And we might even be able to put data loss review into the prioritized list for the 2 years that we haven't left. We can do things like that. So in some of these, would you rather see, so for like allergy testing, I have a second issue that we are gonna discuss and maybe approve or whatever, if we have time, if you guys want to. In January, if we were doing this, do you want me to show overlapping, like this is how it looks on I'm making a change to this guideline, this is how it looks on the prioritized list, this is how it looks in BUP? Or do you want me to like pull those out and the prioritized list change gets discussed first, and then you see sort of just the reflection in the BUP?
This is Mary, I like the first idea, I think that the comparison, if I'm understanding that, I think that makes sense. I'm curious if others thoughts on that, but I think that would help me, especially on like some of the areas that I'm not used to seeing that often.
I like the latter just because we can make the decision about the change and then make a decision about how it gets moved. Like, they're kind of the two separate steps, they're distinct things, and I think otherwise the conversation's gonna get muddled.
I think that from a legal administrative perspective, for the next year, the only one you'll actually have to approve is the prioritized list change. For the other changes, you can give direction to us to make it align with the prioritized list, and we can take care of that detail outside of the meeting if things get messy, so we don't have to group edit 2 different guidelines. Does that make sense?
Right, that's what I worry about.
And then we'd have to bring back, at the end of the process, we'd have to bring back and say, this incorporates, your decisions about a bunch of things on the prioritized list, converts them to the new format, does this look okay? And en masse, that would need to be formally approved by the end of 2026. But the substantive discussion will have already taken place. And it should be just a routine.
Yeah, I like
Like
that.
a translation.
If we could have the substantive conversation separated in some clear way from the routine transfer decision.
Mary Beth, do you want to push back on that?
That explanation makes sense, and it's helpful for me to hear those thoughts. I'm completely comfortable with that.
So I have a question that's maybe a little bit more philosophical. Since we already have CPT codes and ICD-10 codes, why do we need to come up with another code group? If we're really just saying this is covered or it's not covered, or this is medically necessary or not medically necessary, where does this other whole?
That's the pairing.
That's just what they said.
There
So-
could be hundreds of codes in those code groups.
Yeah.
And otherwise, we'd have to list them all out.
I think we spent a lot of time categorizing codes that already exist. And we're just redoing that whole thing, but do we need to, since we don't have
We need to,
we
because
used to
we're,
have codes because we have this list that had numbers and things that are beyond certain lists, but now they don't need to be on a list.
we
Well,
still
they
need
have
to
to
show
have-
pairing.
Yeah, they still have to be on a list, doesn't have to be prioritized, but they have to be in a way that all of the administrative things we
This
built,
links
like
to-
claims.
Okay.
So CPT code pairs with this ICD-10 code in this code group means pay.
There has been some discussion by staff, bigger than just HERC, about some procedures being exempt. So like splenectomy or lung resection. I mean, you're not gonna do that.
Enucleation or whatever.
Right, some of those things, we don't care what it's for because you're not gonna overuse it, so that could be an approach we could use, but then things like hysterectomy, we don't wanna just say, we cover hysterectomy, because we have guidelines, we don't want it done for some things, we want it done for others, so we may treat code.
Well, now you're getting outside of any sort of current process.
Right, okay.
Let's talk about what we're gonna do.
So we're gonna continue to do code pairing. So for knee surgery, like for a total knee replacement, you would still have to have a diagnosis of osteoarthritis or.
Why do you need a code group? I understand that there needs to be pairing of codes, but how does the code group help you?
It's
do
just
that?
where it lives.
That shows the pairing. So.
Okay.
Knee replacement will be code group 10231. And
So that the CCO can deny the claim for total knee replacement for mild knee pain.
Back to the previous conversation. So you were saying separate the discussion by like months between
No,
what
no,
we put on the list and
so what I'm envisioning is for acellular dermal matrix for breast reconstruction, there will be experts coming. There will be a discussion. So we would have what you're used to seeing, an evidence review, articles, guidelines, public testimony, debate. We come up with a policy, and for the next year, the policy would be written in prioritized listees. So it would say, we cover acellular dermal matrix in the fall only when blah, 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 or we don't cover it all. And then when staff go through the breast surgery BUP, there's a lot of stuff that's not controversial. Like all the breast cancer stuff, like breast cancer and breast surgery, sure, whatever. Like, please do whatever breast surgery you wanna do. So you would see the controversial stuff probably first and discuss all of that. And then we would talk about the BUP, and then you just changed my proposed guideline for this. So, we will convert that over, I think. So I'm showing you the older version based on what,
but we
you're
have
still
that,
looking confused, so.
the BUP discussion would be at a different.
No, it'd be the same day, right after.
Oh, okay.
Probably.
What was the other option you were talking about?
So
Was to only go to BUP and not talk about the current the current guideline note first.
Oh.
I thought it was the other way around.
Whatever you
we're
described
building
sounds
the
good.
airplane as we're flying.
Yeah, I'm a little confused about what the options are, that sounds great.
Okay, so talking about allergy testing, because this is a great example, I actually have something in the packet about allergy testing that has guidelines on limits for allergy testing. That's not our current guideline. So if it was our current guideline, it would just be sort of a consent. This is how it looks with the BUP wording changes.
And we will make corresponding changes.
Right, but we'll talk about allergy testing, and then like Mary Ingram's thing about it's not 60 times at 60 units. Okay, we'll edit that. So just like Liz usually does, she would put it up on the screen, it would say units. You would change that, and then when we would get to the BUP and allergies, then.
Part of that discussion same day or later.
Right, it would be the same day, unless it got super complicated and you're like, go back and talk to the allergists. Then we would say, you can approve the BUP allergy changes, but we're pulling this guideline out to match whatever we decide on the prioritized list. And then that would come back to another meeting as like a previously discussed.
But I don't understand what the other option was, but that sounds fine. Yeah.
Yeah.
Or she might make edits to one and we'd say, and corresponding changes to the other, and we do that as staff.
I just think for the next 2 years, it's gonna be easiest if we work off of our current prioritized list of guideline notes.
So if you're gonna bring it back as staff,
Whenever possible.
we have to look at it again some other time.
Well, it'll be on the agenda, because for formal reasons, the final version, every jot and tittle needs to be approved.
Yeah.
But we're hoping the substantive discussion can happen earlier in
But
the
and just like now, like if you, for the CPT codes, if you wanted to approve all of them but one, you guys didn't like one, you wanted more information, you would approve it except for this, and then staff would work on that, we'd bring it back.
Right.
And you guys would approve.
So that'll be a good way to do it, if there's something we identify that needs further evaluation, approve everything except that piece of it, bring it back, okay?
Right. I mean,
So we can get a lot of it done.
And then at the end of the year, you'll see all of your work for the year, and we'll ask if it looks like what you wanted, and you guys' eyes will cross.
Yeah.
But
at the end of 2025.
at the end of 2025, because that's what it'll,
we have like a 4-day retreat planned for that.
I know.
Ariel, this is Chris. I appreciate the discussion. There's a lot of since you guys are doing it over lunch, there's a lot of crinkling, so I'm trying to listen hard. But I'm also a visual person, and I'm trying to I hear what you're saying, but I'm also literally drawing like a flow diagram of what that would look like, and trying to put next to each other the prioritized list down to our process, and then the output there is the BUP that we finish with. So for a while, we're running in parallel, right?
Right, the output for 2 years will be 2 products that we will do our 100% best to make sure are exactly the same.
Correct. Yeah. I think that's a great idea to get ahead of it like that and start kind of having it preloaded and ready to go so it's easy, and then we can check and chunk each section as you can actually get to it. So what I'm seeing is you come with the prioritized list, and your first sort is the items that are direct transfers or have little are not discussion points. Then we use our meeting times to address some of the discussion points like we do. It sounds like are you adding the review with the specialist before you meet with us, or do you expect them to be at our meetings?
I am meeting with all of the specialists now.
Okay. That's great. Okay.
Yeah,
So you'll bring
so-
their feedback to the meetings like you already do in that expert section.
Right.
So then we do the same kind of process like you're saying, where either it all gets approved or we have an exception and you got to make another loop back to pick up whatever pieces weren't agreed on or had discussion. And then we just keep working through that. But what comes out of that is a BUP that we can be ready to launch, and then the updated prioritized list that we're still using.
Yes.
Is that an accurate summary of
Yes.
what?
I think that's a pretty good summary. And then the other piece to that I think we mentioned before, and I just want to warn you about, is that your packets are probably going to be way more than we can do in a meeting. Because for January, we're doing this, we release an advanced packet 6 weeks ahead of the meeting that allows public comment. I'm probably only going to have allergy, ophthalmology, there might be 5 or 6 that I could release in there. And that would be available for 2 weeks for anyone to public comment on.
And is this public comment on the update transition or public?
Anything. And yeah, so we are opening ourselves to everything because we are looking at all the codes. They could pull out, you're not paying for heel spurs, and I think you should, and write a public comment about that, and then we'd have to do.
You'd have to show us when we reviewed it last what the literature was, and we'd have to stick by what we had or reconsider. But depending on the importance of it and the literature strength and the recentness of how it was reviewed, that can be quicker, it can be slow.
Right.
But we might have to listen to public testimony about who knows what and everything.
Right. So far, the allergist and I came to a very happy agreement. The ophthalmologist and I also, they were incredibly helpful. And I think the ophthalmology lines are gonna be very improved. And then we run into things like gynecology and ENT, where I think there's gonna be a lot of controversy about whether we add stuff to coverage that we're not paying for right now. So, Max, what's that face for?
No.
I guess, I want to ask a question kind of above the level. I'm hoping we can focus this group's energy on the clinical decision, and as much as possible, we as staff take the burden of,
That would be
shuffling.
great if we could all commit to letting the administrators do the administrative shuffle and just bringing to us what needs clinical decisions, because I just feel like getting lost in the
We have
administrative
the
shuffle
caveat
sounds
that
terrible, 'cause I'm not good
at the end of the project, you will need to improve every,
True, sure.
but it should reflect your decisions.
So for January, we're gonna be actually talking about allergies. I have a document where I'm bringing,
Can you find that document? Liz?
I have it
For
open.
January.
But like out of like our purposes file cabinet organization, like on this
Right, so
committee, so
for allergy stuff,
I don't wanna do
there
that.
were some recommended changes that would go into effect sooner. There were some, like allergy testing is on the line with, that they told me they had no appropriate treatments for disorders of the immune system, so we would just, so we're doing list cleanup.
Yeah.
That would take effect immediately, next list. So, yeah,
Yeah.
can, if the, like, staff recommend allergy
list-
testing and allergen
For-
desensitization?
For January?
No, it's in November.
Oh, it's in November, sorry.
It's the,
Yes. Sorry, I thought that you were talking about.
so this will be, I think this is actually a really good
This is
test
why-
case to
yeah.
see how,
And that's the gray area, right, or is it list cleanup that requires some decision making that is, requires careful, literature review and evaluation, or is this list cleanup with minimal decision making because it's more clerical than,
it's a mixture. So
Right.
if you see, like, for the allergy topic, there's some list cleanup where there's a line that has, you can just take all the allergy testing off of. Then there was a diagnosis that they really felt was important to cover, so I'm putting it on anaphylaxis line because that's currently a covered line, even though with BUP that wouldn't be appropriate anymore. So you'll see, if you wanna go down to the staff recommendations on that. So it's a mix, so you'll see the first couple things are really just cleanup, but they'll affect the prioritized list. We probably won't discuss that much. She'll be like, okay, the allergist said there's no reason to do any allergy testing for anything on 310, fine, take all the allergy testing off, perfect. Then they had a couple coding issues that they, just because of how they build things and code things to get what they need done. And then they had some substantive changes, if you go down just a little further, and this is, keep going down a little bit further. So like the blue wording, this is, they wanted us to put in these limits, that's where we would talk about, is that the right number? Is that the right, we need units instead of time? Hey, we need allergy, shot limits.
I think what, more than, in addition to what you just said, what's helpful when there's blue text is the reason why they brought it up, and the change is gonna result in, less allergy testing, numbers of times or units per year, because right now we don't limit it, and there are very specific ones. So you just that reason why they
Right.
requested it.
Yes, yeah,
So we
yeah.
understand the effect of what is current state, what this changes, and then the why, and then we can debate it and
Yes.
Yeah,
ask
so-
you for literature clarification.
Let me
But
see if I can.
just saying this, I don't know how this changes things, and I don't know who said it, and I don't know why they said it or what the effect is gonna be, but I need those pieces.
So you need the impact.
Yeah,
So there's two levels to this. One is administrative stuff to make it work legally. Level two is non-controversial clinical decisions that we need your okay on. We don't think there's any controversy, but we need you. That's consent agenda
which
kind of
this
stuff.
practically is, if it's.
Well, no, this is a new limitation.
So
And then the third category is where there's actually a significant change in policy, especially a limit on a service that someone
Was
might think
previously
is
there.
medically necessary and appropriate. And I'm hoping we can we can organize things so that we can focus most of our discussion on that last category.
Right.
And have the first two categories in the consent agenda, and we can say, does anybody have any questions or comments on the consent packet? Hearing none.
And we
move
can
on.
get that in advance, so if there's
Right.
topics that
Just like
we're
now.
content experts
So
at, or really
Jason,
wanna review,
basically you
we
would
can do
want me to
that.
split this into a consent piece and a
Well,
non-consent piece?
Whether
Well,
we
we can't
split
split
it
it.
or we clearly delineate which is which
Okay,
in the
okay.
issue summary.
So in the issue summary, I would put straightforward coding changes, blah, blah, blah.
Right.
Need for discussion,
And maybe we put it in a different font or something to
Yeah,
make it easy
yeah.
to distinguish.
and there was, if you, we didn't show you the whole issue summary, but at the beginning, there's the summary of the discussion with the allergists, and then a discussion of what the changes and why.
If we do it that way, you know, it'll, like, we do put that packet out 6 weeks. We don't send it to you as members. We just send it to our eGov notice thing, which some of you may not be subscribed to.
You need to send it to us.
We need to send it to you as well, is what I'm hearing. And then also we should highlight the key things in a way that you can easily identify them for each issue.
And I think for housekeeping and for expediency, because this year's gonna be busy, it'd be better if we don't have things we like bring back, like if we can finish it like today. So, you know, we can't just like first approve the easy things and then get into the weeds, because then approving the thing that we are gonna change is gonna be a part of the part that we already approved, you know, so it seems like, and if there's a topic where there is something, part of the allergy, a lot of the allergy was cleanup and administrative and simple.
And that can
But
be
we had,
the first part.
but if we do that first and then we do this second, then we're changing the thing.
No,
No.
what I'm thinking we're
This
gonna
won't
do is we'll clearly identify the things that need your input and discussion. Get those out of the way first.
And then say the rest of this is administrative and cleanup and this is what it looks like.
Does anybody
Go.
like have, and somebody may pull something out, like you'll notice asthma or whatever. Oh, okay, let's talk about that. And just that one tiny piece might come back to a new meeting. Sort of as what we do like previous discussion, but it'll just be like.
Okay.
But I think to make it clear, like this example, those previous codes had nothing to do with these codes.
This is a
Right.
separate.
The previous thing that they were talking about that we would put in what we would consider a consent agenda code cleanup had nothing to do with this guideline note where we wanna limit units.
So we could do these two things separately.
Right, so
and
the
in either
clean
order,
stuff
and it
could
wouldn't
be
matter. Okay.
in the one place, the other stuff where we need to talk about it is in new items.
Good, as long as we're not having to like vote on the same thing multiple times because we did it in a goofy order.
We'll do our best.
Right.
It's gonna be complicated and there are gonna be issues that break the mold, but again, the goal is to focus your time and energy on
Right, and then I
the
think
things
just
that
like the
matter.
framework for this, because it would be a lot like quicker and simpler if it's, this is the change, this is gonna limit coverage potentially. This is why, because without, like, there's very clear, only sensible numbers of times or units you can do these per year. So without specifying it, it can be overused with no clinical benefit.
It is currently being highly overused with the feedback that we got.
Good, and then if there's clearly no clinical benefit, then you say, these are the experts who said it, this is the literature.
So you want the rationale. for
We need
it.
the rationale for it, because if I don't know that this limits
So
coverage, then I have a
insufficient
harder time.
evidence, potential for waste, those kinds of things. Okay,
Right,
that's
if we
great.
can have that up front, then we know
Yeah.
how and
What do you
what
mean
in what way.
upfront, like in the
I think she
staff
wants to discuss it,
written?
sometimes this
Yeah.
comes up and we get into it, we're 10 minutes into the discussion
So-
before I
so
realize that
scroll
we're
up to
limiting the
this.
coverage,
If
or
you
that,
can- I think scroll up
Can we
to
add it?
this
This is
staff
Chris.
recommendation, just a second, Chris.
Yeah.
Above that. HERC staff summary, several changes should be made. Overall, these changes will help provide, it sounds like you want more detail there. You want a little more rationale.
But it also is, I'm hearing in the staff recommendations, breaking it into pieces. Cleanup, non-controversial, controversial.
Or
This
doesn't have to, let's not
change
use the
will limit-
terminology controversial.
Requiring
Needs
discussion.
further discussion.
Needs discussion.
changes to current guidelines.
HERC staff heard concerns from allergists about overutilization of tests, and which is wasteful use of money. We are
HERC staff for
proposing,
changes in our current guideline
We're-
allows for overutilization. So the current guideline, what are we doing? We're moving a current guideline to a new guideline. So we need to know what was the problem with the current guideline, what the recommendation and rationale is for the change, and then what's the proposal?
Okay.
So like, what was wrong
So
with this one?
I think we see where you're going. Does anybody disagree with what Katie's saying? Because there's another issue I want to bring up.
Chris had something to say.
Oh, Chris, sorry, go ahead.
I think it's totally, I appreciate that. I think it would super help me too. And I also think if we could figure out how to add it into that plain language summary box, then it would be up front and it's already kind of bullet pointed. And so I don't think it's a lot more information, but it does make it very clear and we know at the beginning of the topic. And the
Great.
general public will know at the beginning of the topic.
Daphne thanks you when she gets back.
So, maybe.
Now, I want to focus on one more thing.
Yeah.
So there's another issue here. Currently, we don't cover allergic rhinitis because of its low impact on health. I think everybody would agree there is some impact on health. Nobody wants a runny nose all the time and headaches and other things that happen. But there is, when we say something's not medically necessary according to that definition, there is room for a decision. Does this make a significant difference in people's health? And there's gonna be some gray area. Is this bad enough to treat? And HERC, a lot of the effect of the prioritized list is to set the bar pretty high for that. And there's gonna be some discussion about warts, allergic rhinitis, services that they have a statistically significant impact, but not a clinically significant impact. And so that'll be a little bit of a change to our discussion. And so any thoughts about how we frame those kinds of issues for you? Like in the past, we focused on things that have a functional impact as opposed to just for appearance, although there's some blur there in, your appearance affects your ability to participate in society because people, treat people differently if they look different. So we're gonna get into those gray areas. Is there any information or outcomes that you'd like to see us highlight or deal with any differently as we prepare those kinds of issues?
One thing I can think of, you just stick with allergic rhinitis, but I can use warts actually too, is so the evaluation and diagnosis is covered. They get to go see the doctor, and the doctor or nurse practitioner, whatever it is, can tell you have allergic rhinitis. It's off, these are the common causes, things that are surrounding us all the time in Oregon.
Right.
But there are really, and then you can get counseled on effective over-the-counter management. So it's not like we're saying you can't be treated, it's just that you're being directed towards, effective, over-the-counter treatments, which I don't think that Medicaid has to cover every single over-the-counter treatment, right? I don't know that that's like.
We do, if they provide rebate.
If there's a prescription, over-the-counter meds can be covered, yeah.
Sure, but I think
it's
in this case, there, effective, non-prescription requiring.
No, but
But
a
for
provider
allergic
can prescribe Claritin, even though it's available over the counter.
And so for allergic rhinitis, currently, you can go to your doctor, you can be seen, you can be told you have allergic
But they're not
rhinitis.
gonna pay for the Claritin.
And you can be
And
counseled.
you can be given a prescription for Claritin and we're paying for it because we don't PA it's so cheap.
Oh.
So that's current state.
One.
So
Right,
some of
so
this is just
Keep that.
moving
Yeah.
the shell, moving it around, it's the same, nothing will change. But in the case of allergic rhinitis, we don't pay for allergy testing and treatment. In the new world, we will, or that's the proposal. So I'm trying to think of if things are just gonna be on the office visit only line, there's really no change for anything below the line. A lot of what we're talking about is gonna be a change.
Yeah, so again, for Claritin, it's not gonna be an issue, it'll be the office visit.
Right.
But the question is, do you want everybody who walks through the door with allergic rhinitis to be able to get an allergy shot? Or if it were
Allergy testing meeting.
or if it's warts, you wanna require them to try compound W or duct tape before they get to the cryotherapy.
One other example that came up with the dermatology discussion, the dermatologists were adamant that we cover freezing of actinic keratoses, AKs. We reviewed that in the past, and there's a very tiny likelihood it develops into skin cancer and then it's still treatable, so we have elected not to treat them. So my proposal that's gonna come forward is that they're on office visit only, they won't get paid to freeze them, they're gonna get paid just like they are now to say it's an AK. And probably the dermatologist may come and talk to you about that. And then we'd have to do an evidence review to see.
Or we can look at how recently we reviewed it.
Right,
We can overview the evidence we've already reviewed.
right, so
Well, but the question is the bar gonna be different? Because, are we gonna require it to have a functional impact still? Are we going to, some of those things that have been put below the lines have been put there not because they're not medically necessary, not because people with commercial insurance don't get them, but because the state has limited funding.
But the state still has limited funding.
It still has limited funding and stewardship is important, but how hard do we wanna push that line will become a more important issue.
And understand commercial insurances have criteria for coverage of treating AKs. The coverage is limited.
So if, what I'm asking today, and answer me later because we're out of time here, but email me, whatever, what kind of information will help you support those decisions so you don't, to minimize the time you spend spinning on those kinds of things?
Right.
I think the potential cost, like, because AK is super common, as is allergic rhinitis at our ward, so like, we're really gonna pay for this. For all, if this is gonna be a coverage change, what's gonna be the impact of that coverage change in terms of dollars, and then maybe compare it, if we could have some standard of, a coverage change, I don't know, and it has to beat some certain standard or something like that. I mean, I don't know. So I think
we're all gonna be learning as we go along.
I guess I'm wondering if, what do we all of a sudden, because we're taking the prioritized list away, did some like huge pile of money show up along with it? Like, why are we now less worried about the cost?
No.
Well, okay, right, so like, we still have to make hard decisions.
We have this
Right.
correcting
And if allergic rhinitis didn't make the cut before, and just because they wanna come and talk to us about it again, why do we necessarily need to let it make the cut this
In a
time?
different situation for gynecology, we have guidelines and we have hearings for hysterectomy for pelvic pain and dysmenorrhea. If I kind of am following precedent, I would just put those on a hysterectomy, like there'd be a code pairing for hysterectomies and we would just move the current guidelines over. Do we want to do that?
Well, the fundamental key difference is instead of saying, sorry, the state doesn't have money for this, even though you might like it, we'll need to say this is not medically necessary for one of the reasons in that definition that we posted earlier. And so that will, that's a little different thing to say.
Medically necessary.
And I see where you're going in terms of doing a cost analysis, but then does that shift our role because we're supposed to look at the evidence?
Yeah, so a cost can influence, like if something doesn't cost much, we'll probably just put it on a consent agenda and say yes, and nobody will raise it. If something's gonna cost a lot, like those AKs, we'll probably have to talk about it.
So again, it's gonna be the cost, it's gonna be the functional improvement of the treatment that has been demonstrated to show. Like, when do you really need expensive treatment for allergic rhinitis? Well, if it's severe and you're missing work or.
Yeah.
That's what we would do, we would put guidelines in.
Right, then we have to have some sort of a specific guideline, about.
Okay.
Criteria.
So I think we've got some general direction, but email us if you think about things, and we will make sure you get the advance packet. And we may present post some supplemental materials as
Exactly, I was
well.
gonna say, when we get the advanced packet, then maybe we also get an outline with, these are the critical points we need to cover. Please be fully informed on these 7 topics.
Yeah.
Do we need to divide it up and subcommittee it out so that a few of us can look really carefully at a few things and instead of all
I think we already do that. We expect you to do all the orthopedics. All the urology. All urology.
All right, so I think we need to adjourn
Yeah.
here. Next
All right.
meeting, January 16th.
January
Can't
16th.
make it, let us know.
We are adjourned. Thank you very much online. Thank you. Hope to see you all in January. Hopefully the weather
And if
holds
we
up.
have limited funds in this state money.
Thanks, Mary.